getting toward the end of the class, so we're kind of wrapping things up. So today's kind of a wrap-up day. We're going to cover gas laws, flight and ground physiology, and Nate's going to go over toxicology, okay? So should make a pretty quick day. All right. So there are how many? 1, 2, 3, 4, 5, 6, 7. I keep hearing talking in the background, guys. Get it out of your system. It's time to listen to lecture. So the type of gas laws we're going to go over today are Boyle's law, Charles' law, Guy-Lussac's law, Henry's law, Dalton's law, Fick's, and Graham's law. And really, there's a lot there, but really there's not a lot. The most important ones are at the top, and the least important are toward the bottom. So when we talk about these gas laws, there are certain components of these gas laws, like the volume of the gas, the temperature of the gas, and the pressure of the gas, also the number of moles that the gas consists of, that work in tandem with each other. So when we talk about these gas laws, I'm going to point it out, but you need to kind of remember that all these different factors and properties are acting on the gas. And whenever one of these things changes, it actually affects the gas in a certain way to behave differently, right? And so, but we need to know for sure that gases are made up of moving particles. They're always moving about, gases, right? They're always bumping around into each other and in other things. They're not just like a moon stationary in the atmosphere. They're moving around. So let's start with Boyle's law. Boyle's law is the most common law that you're going to find on the boards and really in critical care medicine. It says that volume and pressure are inverse to each other, which simply means that when pressure increases, volume has to decrease. And when pressure decreases, volume has to increase. So you're going to hear terms like the variables and the constants. What's variable in Boyle's law is that pressure and volume can change. And when they do, they're inverse of each other at a constant temperature. So if you see a board question that says, hey, what's the law that says at a constant temperature, pressure and volume are inverse to each other? Boyle's law. So you must remember that, okay? It's Boyle's law. What exactly is Boyle's law? Well, Boyle's law is easy to remember when you think of a balloon. B for Boyle's, B for balloon. If I have a balloon here in the atmosphere with helium in it, and it's floating in my hand, and I let it go, as that balloon goes up and up and up and up and up, what's going to happen physically to that balloon? It's going to expand until finally it goes pop. Why? Why didn't it do that on ground level? Why did I have to let it go?
Pressure gradients are different inside and outside.
Pressure is decreasing, volume is increasing.
Yes. Yes. So the number of moles inside the balloon is staying, right? But what's changing? Well, pressure is changing because as the balloon goes up, isn't the pressure becoming less the higher it goes? Okay. If the pressure decreases, then what's the volume in that balloon going to do? It's going to increase. So what's going to happen is the molecules are going to spread out and take up more space until finally the balloon can't handle it and it's going to pop. So this is a balloon on the left at atmosphere, ground level. This is a balloon at 500 feet. And as it goes higher and higher and higher, it's going to expand, 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 and it's going to pop. Right? That's Boyle's law in action. But that matters because we have spaces in our bodies that are filled with air. Well, guess what? Those spaces in our body that are filled with air are subject to Boyle's law too. Some of those spaces are your lungs, your ears, your GI tract, your sinuses. There's free air in your chest cavity, maybe in your head from an injury. Think about mechanical spaces like ET tube cuffs, right? If I am in a helicopter or in an airplane at ground level and I fill up with 8 cc's, by golly, when I'm at 10,000 feet flying, and if I'm not pressurized, what's going to happen to the AT tube cuff? It's going to blow, right? Because Boyle's law says that as the pressure decreases, the volume will increase, right? Air splints, balloon pump, right? Balloon pumps. What does the balloon pump do every so often? Purge, right? And so what's the balloon pump going to do if you fly with the balloon pump? And the balloon pump can see it's in a different pressure atmosphere. It's going to purge. What's that doing? It's resetting itself. It's emptying the balloon, taking a measure of the atmosphere, and then readjusting the volume in the balloon to make sure it doesn't overinflate the balloon. So the balloon pump has a mechanism inherently built into it that prevents that from happening. So it's called purging. It'll take like 30 seconds. The balloon pump actually pauses when it purges, if you remember. And you're like, oh my God, the balloon pump stopped working. But then it'll say on the screen, purging. And you're like, okay, good. Just hurry up, right? So the higher we go in elevation, the more any air is going to expand because any trapped air is going to expand because it has to, right? It can't equalize itself with the environment, right? So Boyle's law is about air trapping, right? So gas trapped in the chest. What if a patient has a pneumothorax, right? If you go from sea level simply to 8,000 feet, that gas expansion will be 33% more than it was at ground level, which is going to make that pneumothorax worse, right? So if you fly up at 18,000 feet, a given volume of gas will expand to twice its size. Now, you don't have to know that for the board. It's just a thing to get you aware of what kind of air movement we're talking about. So that'll take a simple pneumo to a tension pneumo easily, right? But think about open skull fractures, right? Pneumocephalus, right? Pneumocephalus means air in the head. What happens if I got an open skull fracture and I fly somebody from point A to point B? Well, that air is going to expand. That's going to cause some neurologic deficits, right? Which is also going to increase ICP. Calves or cast. If a patient has a cast that's less than 7 days old, it's better to wrap it, to not put the cast on and wrap the injury in a SAM splint. If you do have to fly a person with the cast, then they will do something called bivalving. So they won't cut it off, but you'll see they'll cut a line in it to allow for that gas that's trapped in that leg via the cast to expand. So the plaster cast will expand, and it won't cause the cast to break, but it'll also prevent compartment syndrome on that leg, because that's exactly what's going to happen, right? Is there's nowhere for the air to go. It can't break the plaster. It's going to go the other way and impede upon the leg. So we're going to bivalve a cast. So that's what goes on there. There are 3 types of that. Now, this is 100% on your boards. 100%. They love Boyle's law. They're going to talk about these 3 emergencies. Most common at the top, least common on the bottom. First one, barorectus media, and barosinusitis, and barodontalgia. So the first one is middle ear problems, right? And we all know this. We've all flown here, I'm sure, on an airplane before, and we've all felt the pressure differences in our ears, right? It's not fun when it happens, but what happens is this, right? So we have this tube right here, right? Escutarian tube that's inside our middle ear, and it's designed to deal with pressure changes. But if you've got something going on, you've got a head cold, or you've got a sinus problem or something, this tube can be narrowed or obstructed, and now the inner ear can't equalize pressures between the atmosphere. Here's the atmospheric pressure, here's the pressure in the middle ear. And if it can't do it, what's going to happen? This is your eardrum. Should that eardrum be doing that? No, what's it doing? It's bulging inward. Ow, ow, and we've all felt it, right? Dang it, that freaking hurts. It's because your eardrum is bulging toward the lower pressure. It's being basically pushed by the outside pressure that's greater. So because this is blocked or narrowed or inflamed, it's not equalizing the pressure as well as it should be, and so now we have that problem. What you need to know for sure is that it's a problem on descent. The board will ask you, hey, what kind of problem is this? Is this an ascent or a descent problem? And it's a descent problem. It's when we're landing. When we're going from lower to higher pressures. Right? Just like we saw in this picture, higher pressure, lower pressure. So the atmospheric is having high pressures. We were used to a low pressure. Now we're landing too fast. And now we're getting high pressures, and we can't equalize the pressure in time. It's going to cause the eardrum to do what it do. So what do? We can yawn. We can chew gum. We can do the Valsalva, right, in order to equalize that pressure. If the board asks you how would you treat it, the answer is the Valsalva maneuver, right? Do the Valsalva, which basically is pinch your nose and blow. And you're going to blow, try to equalize that pressure. Also, the pilot can change altitude slower. Second one is barosinus, and this involves the cavities, our sinus cavities, and we can see here we got quite a few of them in our head. The one to take particular attention to is the frontal sinuses. This affects the frontal sinuses more than any other. And this is generally going to be in an unpressurized airplane. So that's why when you're flying in your airplane, you land on a commercial airliner, you really don't have the sinus problems as much, unless you have like a severe sinus infection. is when you're going in an unpressurized airplane really high or you're diving really low, do they have this problem? So it can happen on ascent or descent, but it's primarily a descent problem. It's primarily a descent problem. They do what? Yeah, they're doing a Valsalva maneuver to equalize pressures. I don't know if the bloody nose is associated with, it's got to have just something to do with gases. But I don't know if that's that. That may be something different. But this is just basically a blockage of your sinuses. The declining pressures are not able to keep air in the sinuses compressed, and this results in expansion. Remember, Boyle's law is expansion of the volume, and that's causing a lot of pain and pressure in the sinuses. Not as common as the other one, and this one is the least common of all. It's really when you have a bad tooth. And so it's not going to happen on normal teeth, because normal teeth really don't have air trapped under the root. It's when you have a tooth infection or some kind of issue in your teeth and their air is allowed to get in. You can have air trapped between that, which would cause a lot of pain, obviously, because it's already messed up, and now we got air trap that's expanding. Ow. So it's also called aerodontitia, however you say that word. So know that. So those terms are synonymous. And this is a problem with ascent. This is an ascent problem. Yeah, they change up. So you just got to memorize which one does which. Okay, I was going to put questions here, but I saved them for the end of our day. And that's Boyle's law in a nutshell. As long as you understand that as pressure changes, volume changes inversely, you're good on Boyle's. Right? So what do we need to do to an ET tube cuff if we go from sea level to 5,000 feet? Put water in it, but if we can't do that, take air out before we get to 5,000 feet, because we know that cuff is going to go expand, right? Balloon pump is going to take care of itself. I can't think of anything else we need to be concerned with.
Foley's all have fluid in them already, right?
Do what?
Foley's catheters?
Foley's have air, yes. So, or they have water. They're water filled, so we don't have to worry about that. Because water's not a gas, right? So it's not going to be affected by Boyle's law. Okay, let's move on to Charles' law. Charles' law is a little different. Charles' law doesn't deal with pressure and volume. Charles' law deals with temperature and volume. Remember, as a certain gas is affected by pressures, temperatures, and volumes, it's going to do different things. And so when it does something different, we assign it a different gas law name. So this could be the same gas, oxygen, or whatever gas. But now, when temperature increases, volume also increases. So the gas molecules like to spread out when the temperature increases. Conversely, because it's also directly proportional, when temperature decreases, volume also decreases. So this is proportional, I should say. The variables are temperature and volume. The constant is pressure. So what do we mean? So who's ever baked a cake before? Right? What's it do? It rises. Right? Why does it rise? Because the yeast. Well, what's in yeast that causes it to rise? CO2. CO2, right? Because the yeast produces CO2. It's a live culture. It produces CO2, gas. So that gas is trapped in that batter, and as it bakes, it's still trapped in there, so it's got to release. And as it does, it rises the dough or the cake. It rises, and that's why, because the CO2 is escaping, right? So as you heat a cake, it expands. The yeast in the cake releases CO2 bubbles, which cause the cake to expand. So gases like to spread out with heat. So just like we said, when the temperature increases, volume increases. So remember Charles' law, remember Boyle's law. How do you remember Boyle's law? What's the key word? Balloon. To remember Charles' law, remember cake. Cake. What happens when you bake a cake with the temperature? It rises. So it's going to cause an increase in volume. Gases spread out with heat. And that's going to be important when we think about flying a helicopter in cold weather and warm weather. We'll talk about it a little bit later. Oh, there it is. Maybe I made this, I don't know. I should. So helicopters will fly more easily in cold weather due to the fact that the gas molecules are more compressed, and then doing so it allows more lift. In hot weather, the gas molecules are more spread out and actually will provide less lift. What does that mean? Why does that matter? Because in cold weather, we can carry more weight. Right? We can carry more people, we can carry heavier people, we can carry more gear on the helicopter versus one that's flying in hot weather.
Generally speaking, Brian, like
Well, the pilot has to know weight requirements on every crew member and every patient. Generally, they like to hire people 200 pounds or less.
Okay.
They actually have a weight requirement for that reason.
Like 225 with all their gear on.
Yeah.
and all.
Yeah. So they kind of just target that. Now they'll hire people different weights, of course. They're not being, they're not being. Well, I can't think of the word, but they want you to be a certain weight because there's only so much weight that helicopter can carry, and if they live in a warm environment, then they're going to have to carry less weight than they normally would. This on the bottom, you don't have to memorize it because I've never seen it on the board, but just be aware that for every 150 meters you ascend, you decrease in temperature by 1 centigrade. Or you can say for every 1,000 feet you ascend up, you decrease temperature by 2 degrees. So I've never seen it on the boards, but just keep that in your mind as a test question.
So, we kind of think of going up in the air as like air goes less dense.
Yes,
The temperature's decreasing. Why
and
is it-
temperature decreases.
So
yep.
it's kind of like contradictory, right?
Um,
Because the temperature decreases, technically more dense, and there's less air up there, I guess. I don't know.
yeah, I don't know the physics behind it, honestly, but just know that as we go higher, there's less humidity for sure. And if there's less humidity and there's less temperature, that's what you get when you get higher, when you get less pressure. So, okay. So that was it for Charles Law. That's it. That's all we need to know. So if you see a board question on Charles Law, it's going to be related probably to the cake and the expansion of gases, or they're going to give you a helicopter question like, oh, your patient is flying out of, like Death Valley, Arizona, where the temperature is 105 degrees. Are they going to be able to carry a lot of weight or not, or something like that? You're going to go, no, because I know when at high degrees, temperatures, gas is spread out, it's going to provide less lift, right? Okay, Guy-Lussac's law. So this is a law that deals with temperature and pressure, and they're proportional. So now, as before, they were, last time was what? Last time was temp and volume. Now we're talking about pressure and volume. So pressure and temp, I should say. So when temperature increases, pressure will also increase. When temperature decreases, pressure also decreases, right? So how do we know this? Well, we know this very well, don't we? Living in Missouri, right? So one day you go to your car, tires are fine. You wake up to come out in the morning and one of your tires are flat or have low air. Well, what the flip happened? Right? How'd that happen? Well, probably because it got colder overnight and in the morning it's cold. Well, that explains it. What's going on? When the temperature decreases, pressure decreases. And so when it got cold in the morning, overnight, in the morning, you woke up, there's the same amount of volume is in there. The volume is constant, but they're less packed together. Packed together, right? So here, being that it's warm, they're spread out, remember? But being that it's cold, they're packing closer together. And that reduces volume. So you don't have an air leak. You have a problem with gas law, right? So you need to put more air in there because the molecules that are in there are packed together. So you need to replace volume, but it's not because of an air leak. It's because of the gas law that's caused the molecules to compress.
This is Guy-Lussac's law, right? Not Guy.
Guy. It's not gay, it's Guy. No, it's not. No. Is it gay? Well, whatever. We'll figure it out later. Yeah, look it up right now. I've always taught it as Guy.
I remember because I always found it really funny saying it all the time.
It is gay.
Well, fix your slides.
You don't know that.
Fix your slides.
I was just confirming that.
2024, Tyler.
All right.
Don't,
Can't say that word.
he can change his name if he wants to.
Okay.
Everything has to be gay now. It has to be gay.
I know, now it'll never get out of my head. Now it's, I preferred it the other way, but whatever, Tyler, it's fine. It's funny, there's things we notice. It's just fun. Okay, anyway. So the higher that we go up in pressure, right, what decreases? The temperature. It also decreases. So you may get a board question saying, you're flying in a helicopter at 5,000 feet, your patient's cold. Why? What's happening? The temperature, the pressure is low, so the temperature is going to be low. So keep your patients warm. Okay? That's Gay-Lussac's law. All right.
What if you had a brother named Guy? He has a law too. When you go to the
No, forget it. No, we have to be appropriate. We have to call it gay Lussac
For
slide.
that one, would you say like Lucas for Lucas Tire?
The memory aid for that one is, well, we could. You could. That's a good one. Lucas Tire. I like that. I've never thought of that. So the memory aid for gay Lusac's law is Lucas Tire, because then you'll think about the tire.
Is it oil? Oh.
There's no Lucas Tire.
Okay, whatever. It's Lucas Oil and Tire.
Good year tire.
But I like it. I still like it. There is a memory aid for that. Well, now there's a new one. Thank you, Tyler. But
There's a Lucas Tire and Auto Service.
there you go.
That's what I'm thinking of there.
Yes, yes.
Yeah, Lucas Tire and Auto.
All right. So the big one that the board's really going to want you to know is Henry's law. Henry's law is involved with a lot of different gas behavior, and this is the big one of the day. So let's get through this one here. Henry's law refers to the amount of gas in a solution. What? In a solution varies. Somebody find that spider. But don't flick it at her. That isn't. All right, Henry's law. The amount of gas in a solution varies directly with the partial pressure of a gas above the solution and in the solution at a constant temperature. What does that mean? Well, I like to think of Henry's law as like Heineken. So H for Henry's, H for Heineken. So it involves at a constant temperature the amount of a gas that's dissolved in a given type of volume of liquid, beer in this case, is directly proportional to the partial pressure of that gas that's in equilibrium with that liquid. Don't worry about it, we'll explain this. So we'll explain this, it'll become clear in a minute. So in that can is what? Beer, but what also is inside that liquid that they put in? CO2. They carbonated it, right? They infuse CO2 in that. So beer and soda have CO2 dissolved in the liquid. That's a gas. So it's going to have some kind of behavior, right? So let's just go to a soda bottle because this is easier to see. So in this soda bottle, there's CO2 in soda. But guess what? Some of that CO2 is going to do what? It's going to escape and it's going to land here, right, in that open space. So would you say that the CO2 level in the soda and in that open space are equal? Yes. Because what do gases want to do? They want to go from a what to a what? They want to go from a high to low. So if we infuse that soda full of CO2 and then bottle it and put that cap on it and shut up real quick, what's going to happen is that CO2 sees, oh, there's an empty space there that I need to fill, and they'll fill it. So right now, with this capped soda bottle, there's CO2 in here and there's CO2 in there, even though you can't see it. There's a lot of CO2 at the top there, just waiting to get out. It's trapped.
Is that why when you like crack the
Yep.
top a little bit, it
Yep.
starts?
We'll talk about that. Exactly right. Okay, so that's what's going on so far. Now, just like Kaylee said, when we crack the top, what do we hear? What happens? Well, the amount of CO2 that is dissolved in the soda is now not directly proportional to the atmosphere because it's packed tightly in there. So which has higher pressure, the bottle or the atmosphere of CO2? Obviously the bottle. So what's that gas going to want to do? Go from high to low, baby. Which is why when you open it, what are we hearing? We're hearing the gas that's on the top escaping. And now there's a negative space at the top. So now what does the CO2 in the soda want to do?
Come up to that space.
Fill up that space and even beyond into the atmosphere. So the movement of this CO2 is based on Henry's law. Henry's law is saying that the diffusion of this gas is dependent on the pressures that it's in. So it starts with a gas that's dissolved in a liquid, but it doesn't stay there because even though it's dissolved in the liquid, it cannot stay there. It must come out because it must spread out and fill from high to low pressures. So when you open this bottle of soda, at the top the CO2 escapes, then the rest of the CO2 escapes, right? Gases move from high to low. This is important when it comes to other gases such as nitrogen and divers. This is what happens when we have nitrogen narcosis and nitrogen emergencies in our divers. We'll talk about here in a second. But does this look familiar?
Yeah.
Oh, don't tell me that. Tell me yes, Brian. I love this slide. This slide is phenomenally awesome. I remember this slide. What is this slide demonstrating to you? Which gas law is this slide demonstrating to you? Henry's law. That's exactly right. The reason why O2 is at 160 millimeters of mercury and in your capillaries it's 70, the reason why that can get there is because of Henry's law. Board question. Board question. Make sure you know that the board asks you, hey, how does oxygen get into your body and perfuse your tissues and CO2 get out? Which gas law is that? Henry's law. Henry's law.
Hey, Brian.
Yeah.
Okay, so the one time I left like a 12-pack of soda in the back of my car.
Uh-huh.
It got real cold in the night, and I came out, and the 12-pack of soda was all over my car.
Yeah.
Is that gay, blue stuff?
I would say so. Yeah, I would say so because the CO2 molecules in there. Well, no, that would be the opposite of gay.
I think it's just water.
Yeah, I think it's because, I don't think it would be a gas law. I think it has more to do with the liquid over expanding the container, causing breakage of the container. I don't think it's much to do with gases. But we'll think about that. Maybe it does.
Because it would be, if it's colder, then it would.
Yeah, it would compress. It would compress. Okay, but make sure you know that Henry's law is the gas law that allows oxygenation and ventilation of gases in or out of our body.
Would Henry's law also have to do with like the cabin pressure in a helicopter? Because
Meaning what? Like sudden loss of pressure? Or what are you referring to?
so I don't really know how helicopters work exactly, but I know they always talk about the cabin pressure, and I assume they try and keep the pressure
Yeah.
constant. So
Yeah.
you're not like
Yeah, it's set at a certain pressure.
so
Yeah.
like if there was a loss of cabin pressure, it's because it's too dense in the helicopter. There's some leak, so then
Yeah.
the density in the helicopter,
Yeah.
the gases
Yep.
go outside.
We're going to talk about that later.
Okay.
Yep, good question. We're going to talk about that later. Okay, so what is the real application of Henry's law? Why do we really need to know it? Well, for these guys, right? For these guys. Because remember, what's in that scuba tank? Do we have any scuba divers in here? What's inside it? What concentrations of air is in it?
It's like normal room air.
Yes. So they don't just breathe pure oxygen, divers don't. It's actually atmospheric air. Why? Because our lungs are accustomed to it, and that's what we need, right? It's just atmospheric air. Now, if they dive really deep, really deep, they will have more high concentrations of oxygen. They will. But a normal diver that's diving in your local lake or whatever is going to have a normal atmospheric air, which means what, guys? Yeah, we're breathing in 78% nitrogen. On the surface, that's okay. But if a diver comes up too fast or goes down too fast, right, then we're going to have problems with this, with Henry's law, okay? Because there's pressurized nitrogen in there. It's not like atmospheric oxygen and nitrogen. It's not pressurized, but inside that tank, they're delivering it pressurized. So that adds another component to how much nitrogen they're really getting and how quickly they're getting it, right? Aren't they told to control their breathing when they come up, right? And go down, divers, to control their breathing, right? Because the pressure changes and these gas laws effects. So if they ascend too quickly from the bottom to the top, if they ascend too quickly, if too much nitrogen is saturating the body and the pressure drops too rapidly, the nitrogen can no longer stay in the solution. Solution being what? Blood, right? Or wherever else it's diffused to, into the tissues. It can no longer stay there. And gas bubbles, the nitrogen is going to bubble up like the soda bottle did, and it's going to want to go. It's going to want to move. Remember, gas molecules are always doing what? They're always moving, right? They're always moving. And so something's drawing them out, the pressure change. It's going to draw them out. And where's it going to go? It's going to go in all kinds of places it shouldn't be, right? We're going to get the chokes, the staggers, and the creeps. So it's one person, tell me what the chokes are. Which is going to result in what? Shortness of breath and pulmonary edema, right? So what's happening is the nitrogen that's in the bloodstream is going to go, well, it's going to shift into the bloodstream from the tissues mostly, and it's going to go in and occlude pulmonary capillaries, right? So that's going to cause pulmonary edema and coughing and choking and shortness of breath. Who knows what the staggers are? Not the joints. Huh? Neurological. So what's happening there? Nitrogen is being released into the brain, right? So now it's causing brain dysfunction, and we kind of lose our gait a little bit. And then what are the creeps? skin and joints. So the nitrogen is going to go into the joints because it's an open space that can fill, and it's going to go into your skin. It's going to cause you to be itchy, to feel an itchy sensation or creepy sensation on your skin. All these things are the bends. So the bends compose of all three of those things. That's the bends.
Do we need to remember specifically those three things?
Yes,
Okay.
yes, yes.
Okay.
For the board, for sure.
Is there one that gets affected like before the others, or is it
No, I don't know if that's true or not, but I would think the creeps would go before, because reason why is because nitrogen is stored in your adipose tissue, in your fat cells. And so I think you're going to see the creeps first before the other two, but I don't know for sure. But I would say the creeps first for that reason. But what if you're obese, right? What if you're a little too overweight? That's a problem. If you're a diver, nitrogen is normally stored in our tissues. And that's how we dispose of the nitrogen we breathe in. What happens to the nitrogen we breathe in? Do we breathe it out? Yeah, we do, but some of it gets absorbed in our body. And what's our body going to do with it? It can't use it for oxygenation, so it's going to store it in your fat tissues. And so finally you clear it out, right? So because if we're obese, that means we have a lot of nitrogen stored in our fat tissues because we have more fat tissues. Well, if you put them under pressure changes, then it's going to cause a lot more nitrogen to escape because they have larger stores, and they're going to have much more problem with the bends than anybody else would. And here's just an example of it getting into your bloodstream and causing problems for Henry's law.
And Brian, you said the staggers is
The staggers is the neurologic dysfunction because of the getting to the brain. Now, what kind of molecule? Well, no, that's a different gas law. Hang on, I'll skip that question. There's also something called barobariotrauma, and this is what decompression sickness is. So you must know that for the boards. Decompression sickness is barobariotrauma. You're going to see it used interchangeably. What it is, it's a large and acute release of nitrogen from the tissue, which we know it's worse in obese patients. The problem with it is that since obese patients have a decreased tidal volume, they have a decreased FRC, right? So they cannot breathe the nitrogen out fast enough. So make sure you're aware of that as well. If they can't breathe it out fast enough, then it's going to get into the blood much more quicker and cause air embolisms in the body. Also know that nitrogen has a sedating effect, and so that's part also of the neurological depression, is that nitrogen at a high level in our bodies is actually a central nervous system depressant. So if they have a really bad nitrogen necrosis, then those are the people that are in the coma, they're confused, they go into a coma, and then they actually die from it. So nitrogen has a sedating effect. What do we do about this if a patient has decompression sickness? We replace the nitrogen in the FRC with O2, right? So high flow O2. Let's help them get that nitrogen out by flushing it out like we would do for intubation. And thoroughly pre-oxygenate them if you're going to intubate them, obviously.
Would
A decompression.
high minute volumes help at all?
Do what?
Really high minute volumes?
Yeah, I think so. I mean, I wouldn't make it too high. You want to blow them down. But definitely provide a lot of oxygen to help them flush out the nitrogen, because that's what they need, right? You understand what's happening in decompression sickness is that the body's releasing too much nitrogen because the pressure changes. They ascended too fast. That nitrogen wants to fill, wants to leave. It's going to be everywhere. The lung is going to do its best to breathe it out because that's how it's going to get rid of it. It's going to try to breathe it out. That's how you and I breathe out nitrogen that we store. We just breathe it out like we normally would. They need help doing that, so give them a lot of oxygen. Okay, that's it for Henry's. That's the big ones. Henry's, Charles, Gay-Lussac's. Henry's, Charles, Gay-Lussac's, and Boyle's. Those are the four big ones. You must know those for the boards. I've seen all four gas laws questions on the boards. When we get into these other ones, these are ones you need to be familiar of. I rarely see them on the boards, but it doesn't mean they won't be there. So there's a law called the Dalton's Law of Partial Pressures. It's real simple. It just means that when you add up all the partial pressures in an atmosphere, that they just add it up. So in our atmosphere, we have what? We have oxygen, right? We have carbon dioxide, right? We have nitrogen, right? When you add up those partial pressures, you get a total. That's what Dalton law says. So in our atmosphere, how much partial pressure do we have total? 760 what? Torr, yeah, millimeters of mercury, yeah. So the total pressure exerted by gaseous mixture is equal to the sum of all the partial pressures. That's the definition of Dalton's law. Just saying basically you add them all up and they equal a sum. That's Dalton's law. So as we ascend, right, as we go up in the air, pressure decreases. The concentration of gases remain the same, they're just farther apart. Okay? Which is going to do what to the partial pressures of each gas? Decrease it. So the P total at sea level is 760, but the P total at 10,000 feet is going to be higher or lower than sea level? Lower. There it is. That's Dalton's law. That's accounting for that. It's accounting for changing pressure at your elevation, for the most part, or your depth, wherever you are. So the FiO2 of oxygen at sea level is actually the same at 20,000 feet, is it not? Is that a true statement or a false statement? In other words, is the concentration of oxygen the same here than it is at 10,000 feet? Yes, it is the same. It's the partial pressure that's different. So understand the difference between partial pressure and concentration. An oxygen molecule right now is an FiO2 of 21% right here. If I take the same molecule and throw it real hard and it gets to 10,000 feet, the FiO2 of the molecule is still 21%. The problem is the partial pressure is less. So now oxygens are everywhere. So now I got to go to breathe in oxygen, where right now I can just stand here and breathe in oxygen because they're spread out. Got to work harder for it. And that's why mountain climbers need oxygen. That's why they get short of breath. It's not because they're exerting themselves necessarily. It's because the partial pressure of oxygen is spread out. There's more space up there because you're going into space, and they're spread out, right?
Oh, wait. That's why airplanes have the oxygen mask, like, because you lose
Yes.
pressure
And we're going to talk about that. Yeah, for sure, for sure. All right, so look. We know that the sum of all partial pressure at sea level is 760. We can determine the partial pressure of oxygen. Now, I gave you a chart, but if we wanted to determine it, we could. We could take our total times by the percentage that's in the atmosphere, and that gives us the total of that partial pressure of that gas, right? So the partial pressure of oxygen right here in sea level is 160. On Mount Everest, the total of all the partial pressures is 253. If I want to know, well, what's the partial pressure of oxygen at Everest, times it by 21, I get 53 millimeters of mercury. So at 10,000 feet, did I give you feet? Yeah, 10,000 feet. Yeah, I think it's 10,000 feet. Partial pressure of oxygen is 53 versus 160. Okay? The oxygen molecules are just as effective. It's just that they're spread out more. Okay? So here's my mountain. Here is a visual example of what I just said. At sea level, 760 torr. If I go to 10,000 feet, the total pressures of all the atmospheric gases are less. As I go higher, the total partial pressures of all the gases present are less, until finally I get to outer space, and there are no partial pressure of gases because gases can't exist. Everybody see that? That's Dalton's law. That Dalton's law explains that phenomenon.
Those little oxygen cans you can get from the places in like Colorado and Utah, they
Yeah.
work really well.
Yeah.
I had to buy a couple. I was like double fisting.
Because you went up high, didn't you? Yeah.
I was like,
Yeah.
couldn't breathe.
Right, because it's there, but you just can't get to it as quickly as you would here, right, on ground level. So this is what the board is going to ask you 100%. Given that the partial pressure of all the partial pressure of gases at 10,000 feet is only 523, and the partial pressure of oxygen at that elevation is only 53, golly, if I'm flying a patient that has an oxygen demand, are they going to be affected by that? Yep. So there's a formula you have to know for the boards and for real life where you can determine how much supplemental oxygen I need to give my patient at this altitude. Isn't that kind of neat? There's a formula to figure that out, okay? So how do I determine this, right? So what we do is we take the current FiO2 of whatever the patient's getting. If they're getting no oxygen, then it's 21%, right? If they're on a ventilator at 50% FiO2, then it's 50, right? times that by the ground partial pressure, which should be at sea level, which is 760. Actually, here in St. Louis, we're 500 feet above sea level, so it's a little less than 760, say 750. Is the partial pressure of all my gases, according to Dalton's law. Multiply that by the current FiO2, then divide that by where I'm going to be or where I'm at, the elevation, partial pressure. When I do that, then what's left over is the FiO2 I need at that partial pressure altitude. So if I start my patient at a 21% O2, and here it's sea level, and I fly to 10,000 feet, I need a 30% FiO2 or my patient's going to have symptomatic shortness of breath. If I have a patient, I'm flying at 44% nasal cannula at 6 liters, I'm going to 10,000 feet, I need an FiO2 of 64%, so I need to attach a non-rebreather to that nasal cannula. If I'm on 75% on the vent, patient's intubated, they got a 75% FiO2, I fly to 10,000 feet, I need to increase my FiO2 to 100%. Otherwise, my patient will be hypoxic. Just because you change pressure from sea level to 10,000 feet. Okay? Now, if the aircraft is pressurized, obviously, it's not that big of a concern. But still, we need to calculate this. We need to know how to calculate this. And that's it. In red is a calculation you must remember. It'll be on your next test, and you will see it on the boards.
Will it always be 10,000 feet?
No, I just used a 10,000 feet as a guide, but they'll give you a different elevation. But if they do, they're going to give you the partial pressure for the elevation. You do not have to memorize partial pressures for elevations. They're going to provide it.
Or multiplying the actual percent number, not like 0.21, correct?
No, it's decimal. Do it. Someone do it by calculator, because I don't remember exactly. Is it the real number or is it decimal? Russ, do 0.21 times 760. You got a calculator?
It's 30. I just did it.
It's a whole number? So use the whole number. Yeah, it's not.
Is 63.
Okay, there it is. So use the whole number. So don't put it into percentage.
Round up like
It's like a burn.
Yeah, there you go. Okay, any question on that? Because it's very important you understand that. Okay, let's move on to fixed law of diffusion. Now, we know this law, don't we? Didn't we cover this in like week 2? So all of y'all should be able to tell me everything about fixed law of diffusion, right? Right? It's dependent on it's dependent on 4 things. What are the 4 things fixed law of diffusion is dependent on? Someone give me one. What? Partial pressure of the gas. Good. What else? Permeability of the AC membrane. Good. Surface area of the AC membrane. What else? Chemical nature, permeability, surface area, partial pressure, and the thickness. Those are the 4.
Maybe we did learn something here.
So fixed law is diffusion of gases of higher to lower, but it's affected by the thing it's got to move through. Fixed law states that whatever it's moving through the AC membrane, if it's thicker than it should be, if the partial pressure is low, if there's surface area of the alveoli, if there's atelectasis, obviously no gases can move through there very well. All these things factor into the movement of those gases. That's fixed law. Right? So we understand all that. We just said all that. So make sure you know those 4 things. And finally, one of the final ones is Graham's law. Now, Graham's law is similar to fixed law about moving gases, but Graham's law says, oh, the size of the molecule matters. Right? So who can think of between helium, oxygen, and carbon dioxide, which molecule is the biggest of those 3? Between helium, oxygen, and CO2, which one's bigger? There you go. Everybody hear what he just said? The chemical makeup of CO2 is CO2. 1 carbon and 2 oxygen molecules combined. So that's a big molecule. What's the chemical makeup of oxygen? 2 O's. O2. What's the chemical makeup of helium? 1H. Right? So there you go. So the CO2 is a bigger molecule compared to oxygen, compared to helium. Why does that matter? Well, what gas do we use in a balloon pump? Why do we use helium? We could use oxygen. We could use carbon dioxide. But why do we use helium? Why? Because it's smaller. And if it's smaller, it can move slower or faster? Faster. So the balloon pump uses helium because we got to get air in that balloon and out, in that balloon and out. constantly, again and again and again and again. And so the smaller molecule reduces friction, which reduces heat, which extends balloon life, but also can allow that balloon to inflate safely every time. And if that balloon ruptures, helium is not going to adversely affect us because it's so small, we can be able to breathe it out. We can get it out of our body pretty quick. So that's why balloon pumps use helium. We talked about that. So that's Graham's law. That's an application of Graham's law, is picking helium instead of CO2 or oxygen for the balloon pump, right? It's based on its size. So gases diffuse, go in and out based on their size. So a bigger gas will move in and out slower than a smaller gas. That's all Graham's law says. How fast they move is a measure of their solubility or their size, how big they are, okay? That's pretty easy. How does that matter when it comes to us? Well, when we're flying at altitude, there's less pressure, but with the same amount of O2, right? That means that the O2 is less dense, which affects the pressure gradient the body uses. So in other words, I have to provide supplemental O2 at higher elevations because O2 is so big that it's going to have a hard time getting in and out anyway. Not to mention that the partial pressures are causing oxygen to spread out. I can't get it. But when I can get it, I'm going to have a harder time getting it in because of the elevation and the size of the molecule. Okay? That's why we provide pressurized oxygen through an oxygen tank. Pressurized, so it gets it in, right? And that's Graham's law. But that also explains passive oxygenation. Did you ever wonder in passive oxygenation how on earth the patient isn't breathing? That oxygen is getting from here to here? It is. You ever wonder? I'm not talking about BVMing them. I'm just putting passive oxygenation on a patient not breathing. Oxygen will get from here to here without you pushing it or the patient breathing. How? How does that happen? Graham's law. So make sure you know that for the boards. If the boards ask you, hey, what's the gas law that says if a patient's being apnically oxygenated, how are they even getting the oxygen? It's through Graham's law. And here's how. Now, I stole this from the internet. I cited it because it's so perfectly worded, I didn't want to reword it. So after the induction of apnea, a nasal cannula diffuses oxygen down the trachea to the alveolus. We know that. It is absorbed across the AC membrane despite the absence of respiratory movements, even as you're laryngoscoping the patient. This occurs because the difference in gas production and uptake in the alveolus, the target, there's pressure differences in the target. And the differences in solubility of oxygen and carbon dioxide in the blood. Remember, oxygen is bigger than CO2. It's estimated that during apnea, CO2 is excreted into the alveolus at only 10 liters a minute. Conversely, oxygen can be absorbed at 250 milliliters a minute, right? The resultant negative pressure gradient is the key. 240 milliliters a minute creates a subatmospheric pressure in the alveolus. This results in oxygen being drawn in the trachea and into the alveolus. Okay, so if that don't make any sense, it's okay, but I'm not going to test you on this. It's not going to be on the boards. But basically, it's passive oxygenation due to pressure differences. And that should be no surprise to you sitting in this course.
It's kind of just diffusion.
It's diffusion. It's a type of diffusion, but it's based on the size of the molecules creating a pressure difference. CO2 is going to want to come out, and oxygen is going to want to come in. And because of that back and forth, it's actually drawing in oxygen. Because the movement of these gases. Remember, do gas particles ever stay still? Nope, they want to move and they're going to move. And so they're going to move according to pressure gradients. And that's exactly what's going on. I thought that was really cool when I first learned about it. All right, coming to the end of gas laws. Memory aids. Boyle's is balloon. Charles is cake. Gay-Lussac's is tires or Lucas. Gay-Lussac's. And then Henry's is Heineken or a soda bottle. And that's gas laws, guys. Did you guys get them? Any questions on gas laws? Oh, we're not done yet. Okay, we're almost done. Okay, when it comes to, I added these slides later. So when it comes to diving, remember diving is the big thing according to gas laws, right? How is Boyle's law affecting a diver? We know Henry's law is, but Boyle's law affects a diver too. How so? Yes, Air in the lungs. So there you go. So you need to know that on ascent, right, as we're coming on up, pressures are decreased, which means the volume of gas increase. In other words, the air in your lungs, right, is going to increase as you go up, right? So they're also going to get what? Ear, sinuses. That air is going to increase as well, right? So they've got to have good, they clear their sinuses throughout their dive to make sure that when they come back up, there's no obstructions there. They don't hold their breath. What happens if they held their breath and they're going up? Yeah, the trapped air they're holding in is going to expand, 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 and that could cause a pneumo, right? So they have to breathe in and out, in and out, in and out, in and out. They got to move that air constantly, but at a slow rate to get everything in and out to prevent overexpansion of pulmonary barotrauma. So please know that divers are affected by Henry's law because of the nitrogen, but they're also affected by Boyle's law because of the trapped air in their body spaces. They have to make sure they don't overextend those body spaces. Now going, again, not Henry's law, we recover this during ascent. We know that they can't ascend too quickly because nitrogen will spill out of spaces it shouldn't and cause some problems, basically, forming bubbles in different places that it shouldn't be. We can't breathe it out fast enough, so now we get the chokes, the staggers, and the creeps. Pulmonary barotrauma will result in pneumothorax, a pneumometastaneum, and arterial gas embolisms. Oh, I threw this in too because we need to start thinking about this for the boards. What are some common antidotes? If the board says, hey, what's the antidote for CO poisoning? Oxygen. What's the antidote for methylglobinemia? Methylene blue. What's the antidote for Coumadin? Vitamin K, fresh frozen plasma, or 4-factor PCC. The first two are 99% of the answer. Heparin, remember protamine sulfate. Beta blocker overdose, glucagon insulin. Calcium channel overdose, calcium. And there's a lot more, but those are just a couple I threw up there. And then, hey, you must have those for the board memorized. Remember, for every 10 of change in CO, the pH will change in the opposite direction. For every 10 of change in bicarbonate, the pH will change 0.15. And every change in 0.10 of pH, the potassium will move by 0.6. If you don't have those memorized for the board, you've lost a board question. This is always on the board. One of these are on the board, for sure. Okay. And Nate's not back yet. What time is it? 10:35. Ooh, I ran through that. It's going to be an early day. Anyway, okay, let's move on. All right, so this is a little bit of a longer lecture. This is really, you would think this wouldn't be pertinent as a critical care paramedic, but it very much is. We're going to talk about flight operations especially and some ground operations. Your FPC has a segment where you're going to get this kind of questions. Your CCPC, no questions on this. So that's why the CCPC is a benefit sometimes, but I think that this is an advantage because these questions are going to be pretty easy to know. It's like the gas laws. The gas law lecture we went through, none of that is on the CCPC. It's all in the FPC. So, but it's easy. Memorize the 4 gas laws I told you to memorize, and you're going to get every board question right on those questions. And there's probably 5 or 6 gas law questions on the boards. So, and this is one of those subjects as well where if you're stuck on the CCPC, you don't have to know it, but
Grant, I have a quick question about, so if you're dual licensed with FPC and CCT, do you have to do separate CEUs to
No,
maintain?
no.
So you can apply
Yep,
for both?
yep. As far as I know, because I take the test every time, I've never turned any CUs on both of them, so, but I'm pretty confident that they would take them for both. It's really loosey-goosey up there, I'm telling you. It's like really lax. It really is. Of course, I'm recorded being saying that, but oh well.
At this point, do you even study or do you just go in there because you do this stuff?
I do study. I do. Yes, I do. I do study. You better believe I do. You know what I use? I use my index cards from my class that I took. I told Jen my index card stack this high from the class when I took the class the first time, and I just go through my cards and I study, refresh myself on some things, and take the boards and take the boards and pass. You know.
Do you feel like you need to study that?
What's that?
Do you really feel like you need to study that? How
Yeah,
much you teach?
yeah. I mean, if I took the boards right when we were done with this course, I wouldn't study because but you know. Well, guys, I'm 50. I'm 55 years old. There's nothing in here except for cobwebs, and occasional memories. I'm not smart. You know. Anyway, all right. Ground and flight operations. So all primary care providers must have at least 3 years of critical care experience. That varies, obviously, but according to the boards, they want primary care providers to have 3 years of critical care experience. So just be aware of that. The medical team is required to carry photo IDs. If you notice on the flight teams, they'll always walk around with their badges on their flight suits. It's a requirement they do so. Lights and sirens must be used together. It's talking about ground transport, critical care ground transport. If you're responding, you must use lights and sirens. Ambulance operators are required to complete a defensive driving program. Some of the stuff is obvious because we do it here as a norm. It's got to be an EVOC course. There's actually a co-pilot. You should have a co-pilot on long transfers. We don't do that here at all. We just have a pilot and attendant, but you really should have a co-driver or co-pilot for long transfers. And I can't remember, I think it's greater than 3 hours. A grand transport greater than 3 hours, you must have an assistant driver or co-pilot. Yeah, yeah. Their assigned duties are navigation. They monitor the driver fatigue, and so they must stay alert on all legs of the transfer. They can't sit in the driver's passenger seat and sleep. They have to be awake too. Now the big one is in red. I have seen a board question on the vests, as weird as it is. They're ANC vests. And member of the class. 207-206 is the latest one that I'm aware of. There may be an updated one. But basically, it just kind of gives guidelines on what they look like, how reflective they have to be, what parts of the body they cover. Just be aware that on ground transport operations, if you're in the way of traffic, you must be wearing a vest. We do this now, but when I first started EMS, no one did it. 50% of the rear facing must have vertical surfaces that's reflective in a chevron pattern. And most fire trucks and ambulances today do that. But it used to be you didn't have to do it, but now it's a requirement for ground operations. Scope of care, ICU level care, we know that. Clinical crew, you got to have at least 2 medical personnel. They can be any licensure, but you have to have 2 people that consist of a ground operations critical care crew. Of course, we don't do that here necessarily either. So that's it for that. Now let's talk a lot about the atmosphere. We're going to talk a lot about hypoxia, talk a lot about physiological stresses of flight and how the different pressures in the atmosphere affect you. So we know that the atmosphere extends from the surface of the earth to an altitude of about 6,200 miles. We know that on the surface of the Earth at ground level, it's 760 torr or 760 millimeter mercury. Dalton's law states that because we added all the partial pressures together, and there they are. There are layers there in the atmosphere we need to know. This is in the upper atmosphere, so you must know these for the boards, and you must know the measurements. So 0 to 10 kilometers is the troposphere, 10 to 30 is the stratosphere, 30 to 50 is the mesosphere.
So you said we need to know those.
You need to know those, yeah. You need to know those. Well, convert it to feet on your slide, but it could be either way in the boards. The big one, though, is this. This one I suggest you do, but if you miss that question, who cares? This, you'll have several board questions on. So these are the physiological zones of the Earth's atmosphere that we must know. You must know these three. The first one, from sea level to 10,000 feet, is the physiological zone, or 0 to 2 miles. The next one is the physiological deficient zone, so we've got some problems in that zone. That's 10,000 feet all the way to space. Space is considered to start at 50,000 feet. And then you have a space equivalent zone, obviously in space, which is 50,000 feet to 120 miles. I don't know where they get 120 miles from. Oxygen requirements for a patient are different in each zone, obviously, right? And so we need to know how to do that, how to measure that, and how to provide for that. But you must remember, these will be on your next test, and they will be on the board. You must have these three memorized. Now let's break all three down, starting with the physiological zone. Again, sea level to 10,000 feet. In these pressures from sea level to 10,000 feet, we go from 760 torr to 523 torr, okay? You can be at 10,000 feet and still breathe oxygen and would not have that much distress. That's why it's called the physiological zone, not the physiological deficient zone. Some people at 10,000 feet, though, will have some mild hypoxemia. They'll have a mild headache. If you have comorbidities, like you're fighting a recent pneumonia or there's something going on with your lungs, your AC membrane, you got pulmonary fibrosis, I wouldn't get to 10,000 feet and not expect you not need oxygen, right? But if you've got healthy lungs at 10,000 feet, you should be fine. Maybe some headache. The big one, the big one is night vision decreases at 5,000 feet MSL. We'll talk about what MSL means later, but 5,000 feet. You must know that for the boards. I've seen that on every FBC test I ever taken. Night vision starts decreasing at 5,000 feet. At 5,000 feet, which is why helicopters now carry what? Night vision goggles for the pilots especially, and the crew. They all have night vision goggles now because they fly up to that height. Why? Because it's the rods in your eyes. You remember you have rods and cones? The rods in your eye work with peripheral vision and night vision. So when you get to that high, the rods are ineffective. So you lose night vision. So you must know that.
What is MSL?
We'll talk about that. It's called the mean sea level. We'll talk about that, what that means later. Okay. So the first thing when you're if I ask you a question, hey, what's the first thing that goes in the physiological zone? Your answer is night vision. Because it's 0 to 10,000 feet. And once you get to 5,000 feet, you start losing night vision. Unless you're a rabbit and you eat a lot of carrots. But not too many rabbits fly. So there you go. All right, so that's the physiological zone. The next one is the physiological deficient zone. And that's taking you from 10,000 feet to 50,000 feet. And that's a big jump. That drops you from 523 torr to 87 torr, or O2 from 110 torr to 19 torr, so nothing. You must be on supplemental oxygen in this zone or you're going to have some serious problems. Later, I'm going to show you an 8-minute video. It's kind of funny about a guy who goes through a pressure chamber and they knock him down to 25,000 feet. And it's really funny to see how he responds to the environment. I'm going to show you that here in a few minutes. But just know that the big thing in the physiological deficient zone is that you must have oxygen to survive or be in a pressurized cabin like an airliner, right? They fly at 35,000 feet, right? But we don't put ourselves on oxygen because it's pressurized to, I think, like 4,000 feet, 3,000 feet is what they pressurize it to. All right, and then of course the space zone, there's no slide for that because you shouldn't be there unless you're an astronaut. And if you're an astronaut, you're not in this class, ideally, so we're not going to worry about it.
But you make us feel like we have to be.
I know, that's true. Yeah, might as well work at NASA.
But should we still know the heights for the, like
Yeah, 50,000 feet plus.
That's enough information.
Yeah, that's enough. That's all you need to know. The board won't ask you about the space zone unless it's an astronaut application or something. The big thing, though, is since you're up in these high altitudes, like the physiological deficient zone, if you're in a pressurized aircraft that loses pressure, you need to concern yourself with what? Time of useful consciousness. Because the torr of oxygen goes from 110 to 19, oxygen is up there, but it's way spread apart. So the chance of you being sitting next to an oxygen molecule are pretty low. So you're going to pass out pretty quick. So time of useful consciousness is a term you need to have in your memory bank that denotes deprivation of oxygen. So, hey, that's a good question. How long can we last without supplemental O2? Well, there's the chart. So in space, they say 3 to 5 seconds, you're dead. At 35,000 feet in an airliner, you have 30 to 60 seconds. That's why they say to do what with your oxygen mask? Put it on you first. Because by the time you put it on your kid and you go back to you, you're dead. You have 30 to 60 seconds. Yeah, your kid lives, but then your kid gets cranky and takes it off. Because, yeah,
So that's not on yourself, that's like to death.
that's like to death. Yeah. Huh? Yes, yes, because you got to strategize and prioritize.
Then they end
Yeah.
up disappointing you later in life.
Well, maybe, I don't know. But okay, so that's death. So loss of consciousness can occur anywhere within that time. So that's why they say, without a shadow of doubt, put it on yourself first. Because you may have seconds, depending on our altitude, right? So get you on first, then get your kids on, or your significant other on next.
But realistically, how long does it take for those masks to pop out once
It's immediate, yeah, because they're designed to notice any pressure change beyond what they set it at in the cabin. I've never experienced it. I've never seen it happen, but apparently it's.
What are they doing, a rapid descent though, like immediately?
I don't know if I think the computers are smart enough to see that. I don't know if they will or not. I don't know.
Right.
Okay,
Okay, Ryan, do we need to have the feet versus time memorized?
yeah, memorize that chart.
Okay, all right.
Yeah, and the reason why you have to, because for this next slide, because the board is going to give you 100% what happens with sudden cabin loss of pressure. Sudden cabin decompression is another term you need to know. It'll be on your boards. Basically what happens if I'm flying at 35,000 feet and I have a slow leak, the masks are going to drop. I have got time to put it on. I'm going to last a little bit longer. But if the door blows out, right, sitting next to me, that's a sudden loss. You know what happens to your time of useful consciousness? This chart, it cuts in half. You must know the board will ask you a question. What will happen to the time of useful consciousness in a sudden cabin decompression? The answer is your TUC gets cut in half. Then you're dead. You're dead in half the time than you were before. So it's important if we're flying in a helicopter or in a medical airplane, because remember, critical care paramedics and nurses fly in airplanes too with patients. If you're at 25,000 feet, how do you recognize there's going to be sudden cabin decompression? There are signs. The windows, well, beside the loud noise, the windows will fog. So sometimes that's a board question. If you're flying an aircraft and the windows start fogging, oh my God, what do you need to do? Strap in and hold on tight, right? Because,
freak out the next time
yeah, freak out and scream.
What was there was like a famous plane crash. I can't remember if it was like,
Yeah, it was like a,
you know, where they
yeah.
had fighter jets like go and check on a plane.
Yes.
that had gone
The
wild.
Kennedys, right? Wasn't it one of the Kennedys?
Payne Stewart maybe or something?
Oh, Payne Stewart, yeah.
And the windows
He had a sudden cabin decompression. Yeah, then he died. Died. Couldn't get an auction on in time.
Well, I was gonna say old, I was gonna say seasoned, but yeah.
All right, so here's an example, guys. Here's an example. Don't let me lose you. Stay with me. Here's an example. You're at 25,000 feet. According to the chart, you have 3 to 5 minutes. If you have a sudden loss of rapid decompression of the cabin, you now have 1.5 to 2.5 minutes. Okay, you see what I'm trying to say here. So it cuts you in half. So know that for the boards. Oh, here's the space equivalent zone. Basically what happens in space is due to the atmospheric conditions, it boils your body fluids and turns them into a vapor, then they escape your body.
Is that kind of like what happened with the submarine?
So yeah,
But like inverse?
yeah, yeah,
So like,
yeah,
basically
Yeah.
your inside's just like.
yeah. Well, your body, they go into this cauldron of witch's brew, they boil away. Yeah, so it's real fun.
Do you think there's, actually, I'm not gonna ask that question.
But like,
Temperature is not pressure, what makes it?
I don't honestly, I don't know why they boiled. Maybe the rapid, I don't know. Maybe the rapid loss of pressure is so extreme.
yeah, because
Well, but you also have increased radiation from the sun that high is what I'm trying to say, but just know that. Just don't go out there. Just don't go out there. All right, so let's review this. The board will use all these terms, especially the top three, to explain atmospheric pressure. So atmospheric pressure is 760 milligrams of mercury, or it's 760 torr, or it's 1 atmosphere. Remember I told you if you're at sea level, you are in 1 atmosphere, right? Which is 760 torr. Do not confuse that or forget that. The KPA and the PSI, they don't really use. Remember that if you go down in atmospheres, that's 33 feet. You go down 33 feet, you lose an atmosphere. You gain an atmosphere, I should say, because pressures increase. So you gain an atmosphere. That's not the same going up, obviously, but going down. 33 feet for an atmosphere. All right, let's talk about flight now. There's a lot to talk about with flight operations. Again, you probably should know that for every 1,000 feet you go up, the temperature drops 2 degrees Celsius. So that's why it's so cold up there, right? It gets cold real quick. But the FiO2, or the concentration of O2, does not change, just the partial pressure. Air becomes more drier, becomes less humid because there's less moisture, and colder. So you must know the higher you get, it becomes colder, which means less moisture, low temperatures. You lose moisture as you go higher. A cold, dry, higher environment has a great negative outcome for the patient, right? So we humidify things, right? We keep the patient compartment warm, pressurized and humidified in order to allow the patient to maintain good outcome. Now we need to just review real quick the 4 types of hypoxia. I won't go through them, waste the time to read them. We've been through them before. I put them on the slides for you to review them. Just make sure you're aware of them because they are on the boards 100%. Now, what are the stages of hypoxia? There are actually 4 physical stages a patient will go through before they die. And like I said, we're going to see a video here in a few minutes on it. Indifferent, which means it doesn't really matter. You don't see a whole lot of body changes, meaning indifferent. Compensatory means you see body changes, the body's compensating for the changes. Disturbance means it's beyond compensation and now you see obvious changes in the body. And then finally critical, and then they die. So those are the 4. So indifferent, not any symptoms. Compensatory, they're compensating. Disturbance, there's obvious problems. Critical, they die.
Should we memorize these?
Yep, you should know those for sure. Now here's the video. I want to write, it's about 8 minutes long, so just be patient.
All right, I'll make it super fast. Hey, it's me, Destin. Welcome back to Smarter Every Day. When you're in a jet, if the cabin depressurizes, they drop this little mask out of the top. Well, what happens if you're in a depressurized cabin and you're up above 15,000
Everybody
feet
hear that?
and you drop your mask? Something called hypoxia takes effect, and you got to do something about that. Let's get smarter every day.
You've heard the flight attendant say this before. Secure your own mask before helping others. But why? Why do they say that? Is the 30 seconds it takes to put on a kid's mask next to me really that important? 15 years ago, I learned the answer to this question when I was selected to participate in NASA's Reduced Gravity Student Flight Opportunities program at NASA's Johnson Space Center. Before I got to ride in the Vomit Comet, I had to undergo physiological training in a hypobaric chamber at the Neutral Buoyancy Lab. Fast forward to now. Today, astronaut Don Pettit is scheduled to renew his hypoxia training certification, and I asked him if it would be okay if I tagged along. He let me swim a few laps with him over the International Space Station mock-up in the Neutral Buoyancy Lab before we headed over next door for Don's training.
You look like something the dog dragged in.
I feel like it too. The purpose of hypoxia training is to let astronauts and aviators know when their brain is about to stop working correctly, which is very, very important. If you're at a high altitude in an airplane, the air is thinner, but the cabin is pressurized so your body gets enough oxygen to operate. To simulate cabin depressurization, NASA puts its astronauts in a chamber at sea level and then pumps the air out to thin it out so that it simulates a higher altitude. Don's training starts with classwork, focused on understanding the specific signs and symptoms of hypoxia in his own body. The goal of this training is to understand your own physiological symptoms so that you can take action quickly. For example, Don said he experiences tunnel vision and air hunger, but I remember from my training 15 years ago that I get really happy and start to tingle all over.
I can't take you seriously because this is what you look like.
What do you mean? I look perfectly normal.
This is the experiment we're going to do. Don and I are both going to enter the hyperbaric chamber at the same time and fly up to FL 250, at which point we're going to remove our masks and start to experience the effects of hypoxia. Don is the control. He's a trained astronaut who recognizes the symptoms for hypoxia and immediately corrects for them. I, on the other hand, am under the direct supervision of a NASA flight surgeon, and after I noticed the effects of hypoxia, I've asked if I could delay for about 1 minute so we can better understand the physiological effects of not immediately putting your mask on.
Okay, here we go. We're getting set up.
While Jerry gets me situated, I'm going to talk about the 2 types of decompression. Number 1, rapid decompression. This is like being inside of an explosion. You dump all your pressure instantly, all the moisture condenses out of the air, you're suddenly in a cloud. Very scary, very violent. Yeah, we're not going to do that. What we're going to do is simulate a slow, steady leak. We're going to start at sea level and ascend at 5,000 feet per minute all the way up to 25,000 feet, or as aviators call it, flight level 250.
You can see the altimeter right here above Jerry. He's pointing it out to you. So we're just passing through 10,000 feet of altitude. I want to talk a little bit about the gas expansion. You'll see the gloves here already are starting to show the effects of the reduced pressure. So Boyle's law obviously is telling us that any time we have in the body, as long as the temperature remains constant, we go to altitude, reduce the pressure, then the gases inside that is going to expand.
I'm experiencing Boyle's law in my gut right now. I am too. We're passing gas.
All right, gentlemen, we are coming into flight level 250. What Sharon is going to do is she's going to level off at that altitude. She's going to give us a little bit of a vent to get rid of some of that angle of bank that you guys were talking about. Now that we are at 250, what we're going to do is I need you to disconnect your mask from the right-hand side so that both of you get hypoxia at the same time, even with the mask disconnected. If you could do that for me. So if you'll drop your mask from the right-hand side, turn your regulator off. You can look at the surgeon's gloves. You can see that they are really experiencing some gas expansion. How are you guys feeling inside the chamber as far as the gas goes?
Yeah, good.
And so we're going to start this hypoxia demonstration. Whoever has the toy, if you want to use that for me. So what I'd like for you to do is to pick up a piece, hold it up, show everybody, and tell me what shape it is.
It's a triangle.
All right, so you're going to put it inside the box? Good.
Okay.
Next piece.
Another triangle. Another triangle. Circle. Circle. No, it's a cylinder. It's a cylinder. Cross. Across. Square. Square. That's another cube. This is a cylinder.
We also can see a little purple come around your nose and your lip area.
This is a star.
Now, before we do it again, let's put your pulse ox on your finger. We haven't done that yet. Let's try to check your O2 saturation and see what we're down to. You've been off oxygen now for 2 minutes, by the way.
Roger that.
Don, how you doing over there?
I'm starting to feel like I'm going to black and white and the Looney Tunes kind of thing. My vision is going into just a central spot.
All right, so Don, you can go back on oxygen anytime you want to. You don't have to stay off. I'd like to know what the O2 saturation is on your pulse ox there. What does it read now?
67.
67, okay, so that's a critical area here where you need to start thinking about getting back on oxygen, because once you get below 60, death can occur just like that, right? So you got to realize that you don't want to die. Can we try the shape box one more time just to compare a difference between when you were just starting your demonstration versus right now? We can tell you're really starting to feel the effects of hypoxia.
Triangle?
Yeah, what I'm interested in is to see what kind of coordination he has now.
Starting to tingle.
Yeah, you've been off oxygen for about 3 minutes, 45 seconds. What is that?
Square. And what was that one? That was a square? A square. Are you sure what's this one?
You're starting to have a little shake there, you know, that lack of oxygen. You need to start thinking about getting back on oxygen now, Destin. what would you do? If you felt like you needed to get on oxygen, how would you correct for that? Can you correct for hypoxia for me? All right, so if you don't get on oxygen, you're going to die, right? You're not going to be able to survive this. Go to your regulator, get all 3 switches up on your regulator. All right, go to your regulator, get all 3 switches on your regulator. All right, let's go ahead and put him on for him. Let's get him back on. All right, let's continue on with the shape box.
So we got a square?
You're right, good deal, good deal.
Circle?
Look at that. See, that right there proves how much he's already gone from hypoxia back to feeling 100%.
But this is really important. So this is why on aircraft, they tell you to put your oxygen mask on before you help younger children.
That's exactly correct. Yes.
Because you want to be able to have the mental awareness to be able to save yourself and save others.
If you're waiting, what can happen is that while you're trying to reach over and put that oxygen mask on that child, you may end up passing out from the lack of oxygen.
That's super important. I'm probably going to pay attention to the man or woman that's giving me the pre-flight briefing again.
Okay, I want to make one thing abundantly clear. We performed this demonstration at 25,000 feet and had about 3 to 5 minutes of consciousness left. However, most airliners travel at 35,000 feet. Look at this chart. There is way less oxygen up there. At 35,000 feet, you literally have seconds of useful consciousness at that altitude. You can go from a normally rational person to someone so helpless you can't even save yourself if your life depends on it.
I don't want to die.
I don't tell you this to scare you. I simply want you to understand the physiology behind that little pre-flight announcement. Put your mask on.
Didn't turn on. We will have decreased night vision because we're greater than 5,000 feet, right?
Hey, Brian.
Huh.
Now, why at no point did he or his buddy show any, like, signs of shortness of breath? Just because of
Yeah.
the speed at which it's happening, maybe?
Yeah, I don't know. I don't know why. He didn't really seem to be short of breath. I don't know. I don't know the answer to that. Maybe he was. We just didn't see. Yeah.
He didn't know, you know?
The stupor from the anoxia? Maybe. I don't know. But in the indifferent stage, you're only going to see some slight things. You can still make correct decisions. But once we get to compensatory, 10 to, that should be, oh, so yeah, there's different height requirements. The 10 to 15 is compensatory. Here we're going to see tachycardia, tachypnea, and impaired judgment. Here's our rules we need to know. At 10,000 feet, crew members are required to wear O2 in unpressurized aircraft. During the day and during the night, it's only 8,000 feet. I don't know why. It's just a rule. So make sure you know those as well. The disturbance stage is what we found him in, what he finally ended up being in, right? 15 to 20,000 feet. He was at 25,000 feet, so he was in the critical stage. But body systems can no longer compensate for the changes. His brain was just gone, right? They told him you're about to die. He didn't put it on. So we have dysarthria, impaired judgment, drinking behavior, euphoria, overconfidence. And we saw a lot of that in him. And then finally, critical stage, death is imminent without supplemental O2 within a certain amount of time. So just please know those 4 stages and the keys of each stage. And I'm not going to test you on how high it is. Just know what happens in each stage. All right, so because of that, the FAA has regulations that govern flights, right? Your commercial flights, your private flights, and a commercial airliner. Well, it's the same for medical flights too. Helicopters and planes are under the FAA. And so there are regulations. There's a regulation called the FAR, Part 135, where it governs the use of supplemental O2 by pilots and providers for both pressurized and non-pressurized aircraft. You don't have to memorize that. It should be, say, Title 14, by the way, of Title 14. That dictates the use of the oxygen. I don't think I've ever seen that on a board, just be aware of that. But When you fly, who's ever flown in a medical helicopter here? Has anybody flown in a medical? We've flown in real helicopters, military helicopters, you and I have, and Russ has. But the people that do that every day, if you talk to them, they're going to tell you it's stressful to fly in your body. It takes a toll on your body because you're going from one pressure to another pressure to another pressure to another pressure, another pressure, and it matters. It takes a toll on you. But if I would ask you, between both helicopters, the helicopter on the left has gone from 500 feet, has gone from 3,500 feet, and they experience a pressure change, right? Then the helicopter on the right has gone from 6,000 feet to 12,500 feet. Which crew did barometric pressure changes affect the most? From ground level to 3,500 or from 6,000 to 1,200, 5,000? So who says the left? How many hands do we get for the left? And who says the right? So it's about equal. It's on the left, yeah. Because already on the right, you're at a higher elevation with a lower pressure. So to go 6,000 feet more, even though it's a lot, is doubling it, the effects of pressure isn't that great. As if, though, you're starting at sea level and going to 3,500. And that's where our helicopter crews operate, is in that zone. 0, 500 to 3,500 and back down and up and down and up and down 2-3 times a shift, right, sometimes. So the effects on those changes are great on the patients and on the providers. So it's considered a primary stressor of flight we need to be aware of. Oh, I put it in red. All right, so there's other stresses of flight, right? We have thermal changes. Remember, it gets colder the higher we get. So even if you're in a pressurized aircraft, you're still going to feel that cold, right? In a commercial aircraft, you put your hand against the window at elevation, you can feel the cold, right? In-flight vibration, those helicopters vibrate like heck when you're up in them. That actually will wear you down physically. It'll lead to increased fatigue. The decreased humidity, right? Those helicopters are not humidified necessarily. So they're going to be subject to the low humidity in the air. So your patients are going to have low humidity. So long exposure to dry air will contribute to dehydration, chapped lips, and then the noise. We know they wear these helmets with headphones in them, but you still can't get away from the machine noise. And so that's a stressor of flight that will wear you down as well. Yes, the board will ask you these questions. They will ask you about stresses of flight, and you need to be aware of them. Fatigue. Fatigue is a primary stressor of flight. So pilots cannot fly more than 8 hours every 14 hours. Kind of weird, but they're capped at 18 hours every 14 hours. So you'll see from Arch and Air Evac, sometimes they'll switch out pilots. Or they'll fly with 2 pilots. And the reason why is because one will be a primary pilot, one will be backup, and they'll switch halfway in their shift. So they maintain the time requirement of 8 hours. Also consider gravitational forces. The acceleration and deceleration and the hovering of the aircraft takes a toll on you as well. This is a board question I've had before. Flicker vertigo. This is an imbalance in the brain from constantly seeing flashing lights on equipment, right? So the pilots and the crew have to look at gauges a lot, and they flash. There's flashing lights all the time. That matters at elevation. Like on ground level, you can watch a TV that's flashing all the time, not be nauseated by it, but you'll get something called flicker vertigo, so they'll get dizzy as a result of looking at these flashing lights at elevation. It's called flicker vertigo. And pilots are trained to recognize it and to treat it in themselves to prevent, a complication, but something that you need to be aware of. I've seen that on the board before. There's a frequency, 4 to 20 cycles per second. I've never seen that. I don't think they're going to ask you that, but just be aware of what flicker vertigo is. Some more physiological stress of flight that you must know is the acronym DEATH. So these are the things that are going to contribute to you having negative outcomes from the stresses of flight we just talked about. If you are dehydrated or on illicit drugs, that's a problem. You can't go fly. These stressors of flight are going to have a bigger impact on you. If you fly exhausted, that's why pilots have to get a certain amount of sleep hours before they fly. They're required to document it and track it and log it because exhaustion contributes greatly. Alcohol, obviously, tobacco, and obviously low blood sugar. Stay hydrated, stay fed, stay well rested if you're going to fly because you have to. Otherwise, you may have some problems. Now, I put a break in here. And you're the first class I've never done this. But with the other class, I used to do this all the time. You can ask them. I would send you on break, and when you came back, I would ask you questions about different things. And I haven't done this class because Dr. Tan does most of the lecturing. But he's not here today. So guess what? And I call on you, too. I call you out. Ask my other two classes. So, Danielle, how would you define diabetes insipidus? Okay, describe to me about the ADH levels. Is it too much or too little?
Too little.
Okay. And what are the symptoms of DI? You said peeing too much?
Yes.
Okay, very good. So polyuria. Regarding your water status, are they going to be water-filled or dehydrated?
They're going to have too much.
Too much what?
Water.
Well, they're peeing out too much water.
Oh, so they're going to be short.
So which means they're going to be what? Dehydrated. Okay, so remember that diabetes insipidus is a condition where we have too little ADH, we're going to have polyuria, and we're going to be very dehydrated, right? Okay.
And that's due to trauma, brain.
Well, it could be a result of a pituitary problem, like a tumor, pituitary tumor, or a brain injury can cause it too. Yep. All right, Kyle, let's talk about SIADH. How would you describe SIADH?
The opposite of diabetes.
Like it, it is, exactly right. But how would you describe it?
So if in diabetes we have too much P, which means we have not enough ADH, we're going to have too much ADH in the system.
Yep.
Not producing much urine, so retaining water.
Yep. And what's that going to do to our sodium levels?
Well, if we're retaining water, it's probably going to dilute our sodium.
There you go. So hyponatremia, please remember, hyponatremia is a complication of SIADH, hyponatremias. Low levels of sodium in the blood, serum hyponatremia. Okay? Good. That's all I want. Good job. All right, let's move on. CAMPS. What is CAMPS? We've heard that term CAMPS before. It stands for the Commission on Accreditation of Medical Transport Services, and it's not like a federal organization. I don't think like the FAA is, but it does factor in making rules and regulations regarding flight. And so ARCH, AirEvac are going to be CAMPS organizations. Here at SCCAD, we have a critical care program, but we don't fly. So we don't follow really CAMPS rules as much. They're required to. So it's an organization that recommends standards for transport, and it's the standards they follow, obviously. They focus on safety standards, on professional conduct standards. FAA, we mentioned this already. The FAR Title 14, Part 91, and Part 135, you must know those two things. And I'll describe them here in a minute. So Part 91 applies to all aircraft in the air. Commercial, medical, it doesn't matter. It's called the General Aviation Rule. It doesn't specify day duty hours. That's left up to the pilot and command organization. But it does specify there must be 8 hours from bottle to throttle. You must know 8 hours from bottle to throttle. In other words, a pilot cannot drink any alcohol 8 hours prior to him flying. 8 hours prior to him flying. So the 8-hour bottle to throttle rule. Part 135 does apply to medical helicopters and airplanes. It's specific for that. So, or also applies to aircraft flying for money or are carrying passengers such as us. So air ambulances. So those pilots must follow not Part 91, they must follow Part 95, and the duty day is specified now. So remember, in Part 91, there's no duty day, right? Part 135, there is a duty day. There's an 8 hour, that's when we talk about the 8 hours and 14 hours. They can fly no more than 8 hours in a 14-hour day, which is why we have 2 pilot configurations. If they have a 2-pilot configuration, their flying time can be extended to 10 hours in 14 hours. The thinking is they have a backup pilot right there who's awake. He's a co-pilot. He should be awake, monitoring for fatigue and monitoring for any problems. So that extends. You must know that. They're stricter on the patients accepting due to weather, and Part 135 is more defined weather parameters, which is why ARCH will not fly when it just looks cloudy out. They have much more strict parameters to fly than Part 91. You get a commercial aircraft, they'll fly through a hurricane to get you ready to go, right, it seems? Because they have not as strict requirements. But because you're carrying passengers, medical passengers especially, there are very strict rules on weather. So Part 135 has strict rules on weather. There are 4 flight terminology terms you must know. VFR stands for Visual Flight Rules. And that means that the pilot can see where they're going. There are no clouds obstructing anything. If a pilot has VFR only and flies towards a cloud, he is supposed to do a 180 and fly away. VFR pilots can never fly in bad weather or in clouds. They must maintain visual contact with everything around them. As a result, ATC contact is only necessary when they're in a populated area. IFR is a little more advanced, stands for Instrument Flight Rules. They can fly in adverse weather where visibility is poor and cloud cover is low, right? ATC contact is necessary for all phases of their flight. And that's different. Now all EMS helicopters, pilots have to be IFR. It didn't used to be that way. But now they all are IFR. In other words, they don't use visual to fly, they use their instruments. Right? So they're trained to utilize their instruments to see their location and how to get around based on what their instruments are telling them versus what they see outside.
Whether they're flying a helicopter or a plane?
Yep, helicopter or plane. They are all IFR rated now. And for good reason, right? It's just safer. But that does not mean they still fly in bad weather because they still don't. Right? And we'll talk about why here in a minute. Then there's something called IMC. And this, when you talk about the next two terms, this is related to weather conditions. So IMC stands for Instrument Meteorologic Conditions. So in other words, the weather is so bad that they must fly IFR. They may take off on a flight, saying where they're taking off from, say Columbia, is good weather, but they're flying a patient to St. Louis, and when they get into St. Louis, there's bad weather. Do they turn around? No, it's IMC. So now they must change their flight pattern or the rule from VFR to IFR. That's all it means. I'm flying along from good to bad weather. Oh my God, I'm in bad weather now. It's okay, I'm IFR rated. I'll switch to IFR flying now. That's just what IMC says. IMC says bad weather is here. That's all it means. Then we have a double IMC. Yeah, there's a big drone thing going on. Otherwise, there's the exit if we need it, right? Just grab it. So double IMC. This is inadvertent instrument meteorological conditions. This is where they started VFR but switched to IFR during weather conditions, what I just talked about. So no IMC and no double IMC. Basically, the weather got bad. They could still continue because they are IFR rated. That's basically the gist of it.
Wait, what's the difference between the two?
IMC just means they're flying in bad weather. Double IMC means they started in good weather and they flew into bad weather and now they have to change. It's really saying the same thing. You're flying in IFR conditions. You must use IFR rules because it's a different way of flying.
Oh, it's up there. Jeez.
Are they flying down the hall with it?
Yeah.
Okay, that's not distracting at all. All right, this, I hate to tell you, these next two slides, look, I didn't care about these two slides. These are on the board. You'll have a board question on one of these two slides. I said, screw it, I'll lose the point. Because you have to memorize all that. Generally, I'll give you a hint though. This is the one they have on the boards mostly. So when you're flying local, okay, in a non-mountainous area, this is for visual flight rules only. Remember, IFR can fly anywhere, doing anything. But if you're flying VFR and you're in a non-mountainous area, it's visual, so you have to be able to see 800 feet in 2 miles, right? Or if you're flying at night, you must be able to see 800 feet in 3 miles, okay? Or if you're using night vision goggles.
800 feet, 2 miles, are two different.
No, 2 miles. Yes, 800 feet and then 2 miles. That's what I'm trying to say. Now, at night, you must have NVGs or night vision goggles, or they also have TAWS. You may see this on the board as well. TAWS stands for Terrain Awareness Avoidance System. And that's basically telling the pilot, hey, bing, 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 there's an aircraft in your vicinity. And I'm pretty sure EMS helicopters now have TAWS. I'm pretty sure it's required now these days. But if you're cross-country, the rules change a little bit. And if you're in a mountainous area, the rules change a little bit too. Like I said, I just said screw it and I lost that point. I guessed and whatever. But if you want to memorize those 4 charts, do it. I will not test you on these charts. You got enough to memorize. That to me, that's just, I'm not a pilot. If I was a pilot, I'd have them memorized, right? But anyway, all right, so marginal weather. Weather that's very close to or at the minimums, right? You can fly this, but the crew accepts all the risks. So what happens? We're going to talk about this here in a little bit, but every time Arch Air Evac Firefight gets a flight, The pilot does a weather check, but guess who agrees to go or no go? The whole crew. So the pilot will come back and go, hey guys, we're required to, they're asking us to fly from here to there. There's bad weather. Here's what it looks like. Are we a go or no go? And everybody votes individually. And if one person of the three says no, they don't go. They don't go.
And that's like even if you're like a student on there with you.
Yeah, doesn't matter. Doesn't matter. The whole crew goes or no one goes, which is a good thing.
So, do you know what the causes of those like recent helicopter crashes?
Well, what you must know that the number one cause of aircraft wrecks are weather. But not just weather, pushing through the weather. That's the number one cause of EMS helicopter crashes, is weather complications and choosing to fly through the weather. You gotta know that for the board. Number two is night flying. Night flying in good weather is very hazardous because they hit lines, they hit trees, they hit whatever is in the way. So number one cause of aircraft crashes is bad weather, but just not that, it's the pilot or the crew deciding to push through the weather. All right, so pilot and command qualifications, again, I didn't commit this to memory, but we have to cover it. For rotary wing for your helicopters, the pilot is strongly recommended have an ATP certification, but they must be IFR rated. We talked about that already. I don't care about those hours. Fixed wing, they must file both the VFR and IFR flight plans. I would know that for the boards. Fixed wing, even though they are IFR pilots, they must file both types of flight plans. They must have an ATP certification. ATP is like the highest you can go. They're like able to fly commercial airliners. They must be IFR rated. Oh, and sometimes this stupid question is on the boards. They must have 3 hours of area orientation before they can fly solo. So they must fly in the area they're going to fly in for 3 hours to do map training, basically, before they're released to say, you know the area, you go fly it. 3 hours. So make sure you know that, please. Now, these medical flight crews, what do they consist of, right? Well, they consist of a lot of different kinds of specialties and certifications. You obviously have a pilot. Out here in Missouri, it's required that they have a nurse and a paramedic, but it's not like that in all the states of the union. There are some states, I think like Colorado, that can fly double medic. There are some states, like in the East Coast, that don't fly medics at all. They fly 2 nurses. There are some states that allow physicians to fly as a crew member, and a respiratory therapist flies as a crew member. So you may have a nurse respiratory therapist, a nurse MD, you may have a nurse paramedic, you may have 2 paramedics, you may have 2 nurses. It depends on the state to guideline that, but those are the types of people that can fly and serve as a crew member on a helicopter or a plane. Paramedics and nurses, you must have critical care certification within 2 years. And actually, our flight services out here don't even want you to have FPC or CCPC to get hired. The reason why is if they do have it, they'll take it. But if you don't have it, they'll hire you anyway, and they'll put you through their academy. And then they'll prepare you to take the test, so then you take the board exam, and then you're there with their company. So they kind of train you from the bottom up. So if you want to go fly after the conclusion of this course, go apply, and you're eligible to be hired. You don't have to have board certification. Now, there's something very important that we just talked about a little bit already, medical resource management. It's the idea that, yeah, the pilot is in command. That is called the PIC, pilot in charge. He is in charge of the aircraft. But he is not in charge of the mission. Every person, pilot, blank, blank, the other 2 crew members have an equal say in whether the mission takes off, completes, or turns around. Even in the middle of a mission, if one of the crew members say, I don't feel comfortable, the pilot has to turn around. Has to. If one person gives a no-go, the whole mission is scrubbed. So that's called air medical resource management, right? So 3 to go, but only 1 to say no, which we already talked about. Sterile cockpit is also very important because we don't want people yakking in the back, like the pilot or the nurse and the paramedic to be yakking about what was so funny about that last movie they watched or what's for lunch tomorrow. When the pilot is taking off, landing, refueling, taxiing, or changing altitude or headings. There has to be what's called a sterile cockpit. Sterile meaning no voice communication except what's absolutely necessary. That's mandated by the FAA, and it cannot be broken. So when you see a test question about sterile cockpit, you cannot talk on just BS during these phases of flight. You cannot. If you do, the pilot's going to bite your head off, and you're going to be talked to, I'm quite sure. Reason why is because these are Areas of flight that are what? Prone to mishap. Dangerous or prone to mishap, right? So you just let the pilot concentrate when he's, because they all hear each other at the same time, right? The pilot and the crew members can talk and hear each other all the time. So just be aware of that. That only leaves straight and level flight. If you're in straight and level flight, then you can talk about whatever you want to talk about.
What if like your patient's really, really critical and they're like crashing and it's like one of those points and you gotta like talk to your partner?
Sterile flight. What's more, good question, because what's more a priority? Safe operation of the aircraft or the patient? Yep, absolutely. So it doesn't matter if the patient's crashing or not, you do what you need to do without any words spoken. And by honestly, you're such in a small space, that won't be hard to do. But you cannot break that sterile cockpit. Unless there's a hazard approaching you, then you need to announce, which we'll talk about.
I was talking to, we're flying someone out of like West Alton area, and when they take off from like West Alton area, and they go to like Children's or Barnes, the nurses or the flight paramedics only have like 30, 45 seconds of actual flight time. And so we're on the ground, it's a courtesy for us to call the hospital, give them a report, because they don't have time, because they're still cockpit and hit the air, and then I go to still cockpit.
Well, no, that's different because they're not talking to the intercom system to the pilot if they give a report. They can switch a channel, can't they? And make a report to the hospital. The pilot doesn't hear that.
They told us it was a courtesy for us to call the hospital, because the hospital never knows they're coming, they just know aircraft is coming about.
I know that. But I'm saying if the helicopter crew is calling a report in, it's not on the same frequency of the aircraft frequency. They changed the channel to do that.
They told us they only have like 30 seconds to call a report. So
Okay, well, maybe they don't change channels. Maybe that doesn't make any sense to me. But
the hospital's on a different channel. It's not the same.
yeah, it's not. It's not because it's ATC.
Is it like a time crunch thing or
That's what the crew was telling us.
Maybe so. I'm not going to dispute it because I don't know. But ideally, sterile cockpit means there's absolutely no communication unless it's absolutely necessary.
They were telling us they couldn't call when they were taking off.
They can't. They could. Well, that's breaking sterile cockpit rules. And if they crash, FAA hears that because they're going to run that tape, they're in trouble. They're in trouble. So it's a risk they're taking.
They couldn't give a report to the hospital.
No, I got you. Yeah. Well, that's on them. But I'm teaching you what I have to teach you, and that's some other people may do it differently. But straight level flight's the only time you can yak. All right, flight awareness, reporting hazards. Now, the exception to that is if there's a hazard. Because as a flight crew, your eyes are aware. Outside that aircraft, I know those mishap phases, right? You're not just flimming through your phone while the pilot's taking off and landing. Those crew members are pegged with their eyes outside looking around for hazards. And when you see it, you can't just say, oh, crap, to the pilot, okay? That, like, how many married men in here whose wives, when you drive down the road, it's the worst. Oh, my gosh. I'm like, Julie, stop it. I don't know what you're talking about. What could be possibly so bad that you reacted like that? You can't do that. Look, I drive much better than the wife does, let me tell you. Matter of fact, I can tell you this, honestly, I never get in the car with my wife is driving, never. You know why? Because I choose life. I choose life. And she will tell you, if she was here today, she would tell you, it's true, Brian will never get in the car if I'm driving. I always have to drive, 100% of the time. The only exception to it, if I don't really feel good and we have to go somewhere, then okay, you can drive, but I know I got a 50-50 chance of making it. So, but I'm already feeling bad, so I don't care. I have to feel that bad. Huh? Oh, man. She will tell you. Ask her when you see her. There you go. If you have nowhere to live. All right, so when we see it, when we need to announce something and we have a hazard, we have to report a certain way we have to. Because the pilot can't hear a, oh, crap, or and not know what's going on. So we have to report it as location first, hazard, and then heading. So an example of that was that, like, pilot, we have an aircraft on our left side at 9 o'clock, appears to be heading away from us. That's not a hazard because it's going away from us, but you get the gist. If you report it to the pilot in that order, he's trained to hear it in that order, and he'll know how to navigate the aircraft to get yourself out of danger. Okay, so that's called reporting. So then the TAWS system didn't work, right? The awareness system was not working. Maybe we switched it off. Yeah, don't do that. Don't do that. Yeah, Sidewinder engage, right? All right, so when we do report, we have to use the clock method, right, just like we saw. So that's what the clock method is if you've never heard of it or seen it. So an aircraft on our left side at 9 o'clock means It's at 9 o'clock on our left side. So we don't have to say left side, do we? We can say an aircraft at 9 o'clock descending, flying away from us. Pilot knows look left at 9 o'clock. Okay? So the aircraft of you are always fixated, and then you have to determine, okay, the aircraft is at 2 o'clock. Oh, the aircraft at 2 o'clock. You have to make the determination based on the clock method. So that's what that's referring to. It's not the actual time on your watch. Don't use that time to report aircraft location. Can you use a cell phone during the flight? No, FFA says don't even do it, don't even try. That means texting, that means calling, that means anything. You notice that the flight crew, they carry a bunch of manuals in their pockets and their things, all their guides.
Yeah.
They don't use their phone to look things up. They use their guides. You cannot use your phone on a flight. If the FFA catch you, you'll get a big fine. It's a big no-no. Why? Because it's a distraction. Because it's not only the pilot that's responsible for the safety of the aircraft, it's the crew. So their job should be looking around, looking for hazards. So when they see an aircraft over there, they're going to call it in location, blah, 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 and they're looking for hazards, right? It's a team effort. Aircraft lighting are important as well. On all aircraft, red is always left and green is always right. Why do we put colored lights that are different colors on the wings of a fixed aircraft? So you can tell if it's doing what, coming towards you or coming away from you. Because at night, or if our aircraft is so far away, you can't tell if their navigation lights are on and green is on my right, then is the aircraft coming toward me or away from me? If green is on my right, going away, right? So, right? Yeah, going away. If the green's on my right. Because it's going away from me. See it? I'm looking at the tail. Basically, I'm looking at the tail. If the green is on the right, see that? If the green is on the left, I'm looking at the nose of the aircraft, so it's coming toward me. Helicopters are a little bit different. They have navigation lights a lot of different places. You'll see them on the body, on the tail. They'll see them on the, sometimes you'll see them on the skids, but you'll see lights up here, the white lights, the landing lights. So there's kind of like a schematic of where lights are. So when you see a different color light in a helicopter, you still know which direction it's coming from because they don't have wings. The wings move around, right, the rotor, so they can't put the lights on the wings. So they put on the body of the aircraft. Runway designations are important. Whenever the pilot says, I'm landing on runway 27, what does that mean? Is it just a piece of asphalt that they put a random number on? What does the 27 designate? Designate the area of the compass. So this is saying that that landing strip is on 27 degrees azimuth. So if I took a compass that goes from 0 all the way down to 360, and I turned it to 27, the aircraft, I have to land this way. So that's how the aircraft steers, is by heading. So the aircraft will steer, you hear in the movies, steer to course 27 degrees, whatever. Wherever it's at, if it steers that course, it should run into that runway and land, right?
I have a question. Is it 270? I thought
270.
270.
Yeah, 270. So that would be runway 270.
Okay.
Yeah. Wait a minute. No, it'd be.
I thought and then 12 would be 120 degrees.
No, then what would be 27 then? I think it's 27, not 270.
Are you sure?
Yeah, I'll double check that, but I'm pretty sure that's saying runway 27. You would say that's runway 27 or 27 degrees. Now, sometimes some airports, Lambert's one of them, they'll have several runways on an azimuth heading because their airports are big. So you'll see 27 left, 27 center, and 27 right. That just means they have more than one runway on that azimuth heading. So when the when the ATC says a helicopter land on runway 27 left, they know which 27 runway to land on. Okay. All right, here's those ASL, AGL terms. These can be a little confusing, so we'll just take our time here. ASL is average sea level. That basically means the elevation of the location in reference to the sea level. So where I am right now on the Earth, there's always a reference to sea level, which is 0 feet, right? St. Louis is actually 500 feet above sea level. So guess what? When I'm in an aircraft, what's my altimeter? If I haven't reset my altimeter for sea level, what's my altimeter going to say in the aircraft? 500 feet. What the pilots do is they'll reset it, and then the computer knows to add 500 feet to any elevation they take, right? So if I hover to 10 feet, I'm 510 feet above sea level, but I'm only 10 feet above where I am. Ever got that? So that's what ASL means. ASL means where is that location at sea level? St. Louis, we're 500 feet. Well, then, okay, then how far am I above the ground, though? That's AGL. AGL references the altitude above the ground and sea level. So that's called your relative altitude. Right? So AGL references the altitude of the ground, aircraft above the ground and above sea level. MSL is the one they use mostly, and that's your mean sea level. That's the altitude that takes the ASL into account, right? So in other words, helicopters normally fly from 0 to 5,000 feet. They cruise around 5,000 feet max. So say Arch is flying 400 feet above the ground in St. Louis, what would be their MSL? Well, it would be 900 feet, mean sea level, because we have to factor in the sea level, and we have to factor in they're flying at 400 feet. So if they don't reset their altimeter, they're going to be flying, their altimeter is going to say 900 feet, because it's going to take into consideration they're 500 feet above sea level, but they're only 400 feet above the ground. But if they reset their altimeter to 0 before they take off, and they're flying at 400 feet, their altimeter is going to say 400 feet. You get it? That's all a pilot thing. As a crew member, we're not concerned about it, but the board and the boards think you should know that. So in other words, mean sea level, above ground level, mean sea level, right? So there's the difference between the two as visual representation of the two. All right, flight following. Does everybody understand that? Everybody good on that? Belgium is calling me. Wow, I should answer it. Maybe it's a free trip. Everybody understand the difference between AGL and MSL? Those are the big ones. So mean sea level is the most important one. If you see it on the board, it's going to be MSL. That's taken into consideration where they are at sea level. Right? St. Louis is 500 feet above sea level. They're flying at 400 feet elevation. Their altitude is what? 900 feet. But if they want to say screw sea level, who cares? They're going to fly at an AGL, and they're simply 400 feet above the ground. That's what we commonly think of when helicopter flying. They're just 400 feet above the ground, or 1,000 feet above the ground, 5,000 feet above the ground. So they can fly with either rule, with either guideline. Okay, when it comes to flight following, it's kind of an interesting thing. You know, these helicopters fly all over the country, and their dispatch centers are where? They could be anywhere. They could be states away. So how does that dispatch center know the helicopter is okay? Well, they do what's called flight following. So it's a way for the helicopter to communicate with the home base or with ATC, whoever's tracking them. And so what happens is, for every 15 minutes the helicopter is in the air flying, every 15 minutes they have to radio back to base to go, everything's good. Here's my location. Every 15 minutes of flight, the pilot has to do that. If they're on the ground, say they landed at West, they shut off their propeller, shut off the rotor, they still have to call it every 45 minutes. We're still here, we're still waiting on the patient, life is good. Every 45 minutes. The reason why is because, why do you think? Why is it every 15 minutes during flight? Why 15 minutes? Yeah, if you crash. So if I called in 15 minutes and I crashed 1 minute later, then I'm only 14 minutes away from that last location. So they can geofence and go, okay, I know they were flying from this point to that point. Their last check-in was here, and now they don't check in after 15 minutes. They're obviously in this area here. So they can send resources to a specified area to try to find you, right? So it narrows down your location, even though they may not know exactly where you are. They know kind of where you are. And in 45 minutes on the ground, they just want to make sure that you're still there and you haven't gone off and flown off without checking in.
Does dispatch ask no different than 20-minute market checks for us?
Yeah, exactly right. It's what it is. And so their dispatch center, like Air Evac used to be here in O'Fallon, right? Is it? I think it moved. It still is? Yeah. So that's the center that called out for all the Midwest. Those dispatchers sit in there and talk with all helicopters from Air Evac. And they flight follow them every 15 minutes in flight and every 45 minutes on the ground.
Hey, Brian, I just texted my brother, who's a pilot.
Oh, okay.
And I said, random question, we're studying flight physiology, what does the number on the runway indicate? Where does it come from? He said, approximate magnetic heading, not exact. Runway 24 would be approximate magnetic heading 240 degrees.
Oh, you're right. Well, then what's 24 then? How do you designate 24 degrees?
How do you what?
How do you designate 24 degrees then?
I'll ask him.
Yeah, ask him. Russ was right. Congratulations. Extra point in your test. Oh, well, it was you, right? Russ who said that? Oh, Kyle. I'm sorry, Kyle. Yes. All right.
+1 point.
Also, when it comes to flight following, That's what it is. It's called the emergency action plan. So whenever a helicopter or a plane doesn't check in after 15 minutes, they activate what's called an emergency action plan. And then they go into effect to try to find it. Now, these helicopters are equipped with GPS systems, so they can find them. You need to know the transponder frequency. The transponder frequency is 406 to 800. You have to know that for the boards. The boards will ask you that question from time to time. And it will always be in the cockpit within reach of the pilot because he can manually ping it. He can manually say, ping, here I am. So if he has time prior to crashing, he can ping it, and dispatch center will know exactly where he is because they're on that frequency.
406
millihertz to 800 millihertz. That's the frequency for that transponder that's going to activate that ping or that GPS. It automatically will send an update every 3 minutes anyway. So they're still going to do the 15 minutes following as a backup, but the GPS systems, and now maybe these days, maybe even quicker, they're going to send an update every 3 minutes. If they do go down, then guess who's going to respond? Your local Civil Air Patrol. I had an aircraft crash. My only aircraft crash here at SCCAD was probably 16 years ago. It was actually a Creve Corps firefighter who had his own private plane, was flying around during the day doing acrobatics, and crashed. And he came down and he couldn't pull up and he pancaked right in the field. I got to tell you, it was brutal. It was utterly brutal. He blew out his elbows, he blew out his knees, he blew out his head. He blew everything out that he could. It was brutal. And then as we responding, I could see aircraft flying over. And as we got on scene, there was a Cessna flying over us, and that was a Civil Air Patrol that had responded. Because their job is to get out there and fly out there and search from the air, bird's eye view, right? Because we don't know where this aircraft is. Well, luckily, he pancaked in the field in view of other people at a park, somewhere out there in St. Charles. I don't remember where it was, but it was not great. So he ended up passing. But I did see the Civil Air Patrol in action, which is kind of neat, I guess. So they'll respond. It's all volunteer. It's not an Air Force pilot. It's a civilian pilot that's volunteered to work for the Civil Air Patrol. And out here, we have a chapter out here somewhere. St. Charles, I think I want to say, somewhere out here, we have a chapter of Civil Air Patrol. And you can join it as a kid. You can learn how to fly. A lot of pilots that joined the military started the Civil Air Patrol, learn how to fly, and then go on to be military pilots. Here are some just miscellaneous. We're only getting near the end of my presentation. So critical care providers must complete 5 live intubations before being released from missions, and then they must maintain that bi-quarterly. So it's not like us here in the field. We don't have to intubate a patient. I haven't intubated a patient in probably 2 years. I just haven't. So, and I can still do it tomorrow. But the flight services, it's not the case. They must have 5 live intubations and then maintain bi-quarterly intubations. You must know this for the boards. Flight suits must be flame retardant and be able to pull away by only 1/4 of an inch. That's a board question on the FPC most of the time. 1/4 of an inch.
So they gotta be tight.
They gotta be tight. And you notice that when you see those flight crew members, they look good. They look good because they're tailored flight suits, you know. So they wear tailored flight suits because they can only be 1/4 inch away. They measure them and tailor them and suit them. So can they gain weight? It's not a job where you can just gain weight, right? Very easily, because they're going to be mad because they got to remeasure you. The PIC, which again is the pilot in command, has the ultimate authority of the mission, but when it comes to crew management, all crew members are equal, right? All crew members can say, stop a flight, turn around, or it's a no-go, right? But the PIC has command because he's the pilot. He's the ultimate authority. Again, we talked about this earlier. Long-range flights are greater than 3 hours. Long-range flights are considered greater than 3 hours. You cannot unbuckle during flight unless you're flying straight and level, or if the pilot tells you to, which I don't know why you would. Okay, the safe aircraft, we talked about this, the safe operation aircraft comes before any patient care, because we want to be able to go home at the end of the shift. We got to wear boots, you've seen the flight suits have reflective material on them, that's required by CAN. They have to wear vests at night, which we've seen them do. And their helmets have to be inspected at least annually. That was a board question on my last FPC. Their helmets are very delicate instruments, and they have to be inspected for safety, and of course they have microphones in them and everything else. Make sure the hearing protection component of it is working well and all that. So annual inspections on their flight helmets are necessary. Okay, right at break time. How long do we need? We don't need a break, so I'm almost done. I do have some questions for you though.
Stop smiling like that.
It's funny because then everybody looks down and gets awfully busy. Jacob. That Jacob. What are the 3 kidney hormones?
3 kidney hormones?
Yep. And second, Jacob, I'm coming for you next. But in my heart, you're the first Jacob. Just saying.
It's okay, I'm already.
Come on, give me one.
I said renin.
Yes, thank you. Renin, what else? What's the purpose of the renin? It produces the, it contributes to produce the aldosterone.
Okay.
I'm sorry, the angiotensin. The angiotensin 1, which converts to angiotensin 2. Okay. So renin is 1. What's the second one? I already gave it to you.
Angiotensin?
No.
Aldosterone.
Aldosterone. What's the purpose of aldosterone? To regulate which electrolyte?
Sodium?
Sodium. Good. And then what's the third one? Donovan, help him out.
Oh, listen to that last part.
Okay. Russ, help him out. What's the third kidney hormone? Renin. Well, you're missing the big one, friends. Aldosterone and, ADH. You said it?
I thought you said it.
Yes, thank you. ADH. What does ADH do? Helps the body retain water. Antidiuretic. Okay. Jacob, what's the normal BUN creatinine ratio? Well, let's just back up. What's a normal GFR value? Glomerular filtration rate, GFR. What's the normal value? Close. Yeah, anything less than 90. So good.
More than 90.
Oh, I'm sorry. No, normal is, did I get that backwards? Normal is under 90. Anything greater than 90 is abnormal. What?
More than 90.
alligator mouth is
Less than
facing
90,
down.
you're filtering.
Oh, you're right. Okay. My bad. Okay. So what's the normal BUN creatinine ratio then? Are you typing it out, looking up?
No, I'm
Oh,
typing it
okay.
out.
All right. Okay. Because that would have been slick.
What is
10 to 1, 10 to 1 to 15 to 1. 10, because I can. 10 to 1 to 15 to 1, BUN creatinine, which means your creatinine level should be 10 times, the BUN level should be 10 times the creatinine, correct? 10 to 1 ratio. You can go as high as 15 to 1 with older patients. Remember in older patients that extends? All right, do you have any other questions? Oh, yeah, let's ask Jen. You look busy over there, so I'm going to interrupt you. Which medication is given for variceal bleeds, and the purpose of it? No, I'm not going to do that. I'm going to ask someone else that. What medication will we give to the patient having a variceal bleed? What's the first medication we need to think about giving them?
TXA.
Okay, that's good, but that's not the one I'm looking for.
Okay.
When I say variceal bleeds, it should pop right into your head.
Okay, well, it's not, if I'm being perfectly honest.
Starts with an S. Think of a beach.
Sexy.
Well, that's one good choice, but no.
Sex on the beach.
What's on a beach? It's made of what? Sand. So what's this medication I'm thinking of?
Okay, everybody else has a crazy.
I don't know.
So.
All right, throw it out. Who knows it? Say it again. Sandostatin.
Yeah, I'm not right.
Danielle, what's the purpose of giving Sandostatin in a patient having variceal bleeding?
To clot.
Okay, but better than that. Do better than that. It's to do what? It's to stop the bleeding, but how is it going to do it? By reducing pressures where? Portal pressures, which means pressures where? In the liver. Well, not just the liver, but the blood vessels to the liver, right?
Yes.
Because remember, those blood vessels extend to the esophageal blood vessels, right? And the esophageal blood vessels are bursting with blood because the portal tension pressures are high, translating to the esophageal blood vessels.
Somebody spell me the sand or whatever.
SANDOSTATIN. And finally, Adam.
It's like simvastatin, but not.
What organ problem will demonstrate with Kerr sign? What organ problem will demonstrate with Kerr sign? No. No. Well, pick an organ. Don't say heart. Kerr sign. Come on. Huh? No. Spleen. 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 It's a referred for spleen. Isn't this fun? Do you miss this? I should have done this all course for you guys. Yeah, I did this last 2 years. Anyway, we're almost done, then we'll go to lunch or a break or something. Okay, let's talk about helicopter landing pads or zones. Okay, so this is a typical fixed, I should say fixed. The board loves to ask you questions on landing zones. So make sure you know everything about landing zones for the FPC. All right, so we're looking, what's the size? 100 feet by 100 feet. That's the size, the minimum size of a fixed landing zone. You must know 100 feet by 100 feet, okay? And that's what it looks like. We'll talk more about it here in a second. Also, you must know the danger areas. Obviously, the danger areas are the rotor, but that's high, but what's worse? The tail rotor, right? So that's a danger zone. So make sure you definitely know. The safe places are catty corner to the pilot's eyes, because the pilot can easily move right or left and see you. So know where the safe spaces in approaching a helicopter are. They're to the side. Why is this not a safe space? And it has to do with the rotor. It tilts down. It does. It tilts down. So it's not a safe space. It's just a cautionary. So never approach the helicopter straight on. Always come from the sides. Never go near the tail rotor, because that would be bad.
The video of the Navy guy jumping into it.
Yeah.
Committed suicide, jumped into it, he disappeared.
Yeah. It won't. I mean, what are you going to do? You can't. It's not going to bounce off you, friends. It's going to take a chunk out of your head. All right. So when it comes to these permanent or fixed spots, you must have 2 approach and departure headings. You must know this. Think of the one at St. Joe West. How many approach headings does the pad at St. Joe's West have? Don't say 4.
At least 2.
Has 3. What's on the other side that's the pilot can't come through that side? The building. So the pilot can't come from that side where the building is, but the other 3 sides the pilot can approach from. So that landing pad fulfills the requirements having at least 2 approach and departure headings. The one at West has 3. The one at Mercy, St. John's Mercy, has 4. There's no building around it. They can approach from any direction. They must have perimeter lighting on the helipad. There must be lighting. It must have a landing beacon or some kind of light on it, and it must have a windsock. So these are things you must know for a fixed or a permanent landing pad requirement. If they're flying into an unsecured landing zone, like a scene flight, they must have communication with the ground units. Here we use fire mutual aid. So that's why we wouldn't direct an aircraft in. Fire would do it, because it's on their channel. And that's what they do. They do it. The pad must be at least 1,000 feet square, so it must be 100 by 100. They must land with the nose of the aircraft downwind. Now, how many times you've been in a scene flight with Archer Air Evac and they just flew around for a while until they finally landed? Do you know that they have to do that? So they must make 2 passes. They must make a high pass and then a lower pass before they can actually land. And what are they doing? Looking for obstructions. Now, that's just going to come in hot, like a military helicopter would in combat or something. They're going to safeties first. So they're going to make a high pass, no obstructions, make a lower pass, and then they're going to come in. Or sometimes I've seen them make a high pass, and as they're coming in, they're making a low pass. But either way, they're going to do a high pass. They're required to do 2 passes, one high, one low. And they must have 1 approach and departure heading, so they can't land into a place that's blocked off by 3 things with only 1 way in. They got to have 1 way in and 1 way out to be used as an emergency. So they must have 1 approach and 1 departure heading to fly in. To market, I think I had a board question on this once too. I can't remember what it was, but we market by several different ways. You can market with headlights from vehicles, or you can use ward flares. You can use chem lights, but they can be blown away, so it's probably not a good idea. You can use emergency vehicles. I think that's what my board question was. How do you use emergency vehicles to light up a temporary pad? And basically, you park them at the corners. You see what they're doing here? Emergency vehicle, with the concept of where the headlights cross is your landing spot. So we wouldn't put on all 4 corners. We'd only need 2 on 1 corner. So where the headlights are crossing, the pilots can see that from the air. That's your landing spot, okay? So where they intersect. And that's to give the pilot in dark better direction, other than looking at a pilot with his hands, or a ground person on their hands in the night. We got to use some kind of light. And so there's several ways you can do that to designate where we want the helicopter to go. All right, when it comes to in-flight emergencies, this is always on the boards as well. there are 3 categories of in-flight emergencies and how the pilot responds to them. So one is, hey, land immediately. The other one's land as soon as possible, and the other one's land as soon as practical. Land immediately, obviously, is engine fire. If my engine's on fire, it doesn't work that well, so let's get down. If there's other fire or structural problems, then let's get down. Land as soon as possible and land as soon as practical are less emergent, as you can see. All right, let's talk about crashing. What time is it? Okay, we'll go to lunch after these 5 slides. And then that completes all mine. Then it's up to you for talks after lunch. Okay, crashing. A lot of board questions on crashing, guys, a lot. So when you're going through a pre-crash, follow the pilot commands. That should be obvious. He will relay the communication center, the dispatch center, wherever he's talking to. He will relay to them on the radio if possible. He will knock that GPS and activate it. And if he has time, he will activate the black box, because you can actually physically turn that on and activate that as well. But we'll talk more about that. As he's going through the pre-crash shift, if he has time, he's going to disable power converters, turn off the O2, you're going to put on seat belts, you're going to lay the patient flat, and more importantly, I did get a board question on this once, what is the crash survival position for the crew members? And what it is medical providers sit straight up, knees together, feet 6 inches apart, not under the seat because you'll break your feet. Cross your arms in the chest and put your chin down, not your whole body. Put your chin down like that. And that's supposed to be the helo crash position for crew members. And it's not like the aircraft say, the commercial aircraft say, lean forward against the seat in front of you. That would be not a good thing, I don't think. But yeah, so tighten your strap and lower your visor. Lower your visor is important too. They have to lower their visor because debris is going to happen, and we don't want that hitting your eye, because now you got to get out, and you don't need to have an injury to your eye trying to get out of a helicopter if you survive the crash. So tighten the strap and lower your visor are important as well. After you crash, there is a board question that wants you to know the first thing you turn off, and it is your responsibility as a crew member to do this, not just the pilot's. If the pilot is incapacitated and can't do it, it's your responsibility before you exit the aircraft to turn off the throttle, the fuel, and the battery in that order. Then the rotor brake, and then the oxygen. The oxygen should already be turned off, because it should be off if you're not using it. And in pre-crash, you should turn that off. But if it's not off, turn off there. Then exit the aircraft and always assemble where? The 12 o'clock. Always, always, always. If you can't find the 12 o'clock because it's mangled up, it is what it is. But they want you to meet at a centralized location. Why?
So you know if everybody's coming.
Yeah, because one person stumbles that way, another person stumbles that way, and now you got to search for each other, and that just takes time. What if the person that stumbled off is injured? They can't get care they need right away. So try to assemble everybody at the 12 o'clock position. That's at the nose of the aircraft, wherever the nose is. That's where the meeting point is, if there's still the nose there. Obviously, treat any injuries and rescue anybody, salvage any equipment that can be salvaged. 100% board question, 100%. The first thing you do when you get out, after making eye contact with everybody, and then, of course, making a Facebook post and that you survived and how fun that was, is to get shelter. It's not to get water, it's not to get fire, it's not to get food or water, nothing. First thing you do is establish shelter. First thing, board question every day. You must find shelter first. Obviously, the aircraft is not shelter, so you got to find shelter. Then get a fire started, then find water, then find food. And then worry about being rescued. Signal for help, communicate. Aircraft have a survival bag on board. They're filled, every aircraft has one with food, I guess MREs, I'm not quite sure what they carry. Water purification tabs, matches, blanket, mirror, and medical supplies. They have a survival go bag on every helicopter. The black box, called the emergency locator transmitter, is on every aircraft. You have to know, for the boards, it will impact at 4 Gs. If the aircraft crashes and has 4 Gs, which is easy to do when it's crashing, it's going to automatically activate it. But you can also manually activate. The pilot can manually activate it as well. So if he knows he's going down, he can turn it on and it'll start recording. The good thing about it is not just that it records what's going on, it has an alarm on it. So it's going to emit. Once it's activated, it's going to start emitting a ping at a certain frequency that the Civil Air Patrol are going to listen to. And that's what's going to dictate getting them. Of course, with flight following, we know where they were less than 15 minutes ago. And now we've got pinging in our headset at a certain frequency. We're going to facilitate rescue quick. You must know those frequencies. 121.5 was on my last FPC. The new one is 406. I heard that they changed that on the boards to 406. 406 frequency connects with satellites. It just doesn't put out an area that you have to be within 10 square miles to hear it. The 406 frequency connects to satellites, and now the range of that pinging is much more extended. So they can find you 25 miles out. They can get your ping and go to where you are. So much better, obviously. But know that 121.5 is a local. It doesn't go very far. I don't know how far it goes. 406 uses satellites, and they can get that ping much further. All right, survival principles. Obviously, we can survive 3 minutes without oxygen, 3 hours without shelter, 3 days without food, 3 weeks without food. Just remember those. That's it. So any question on ground and flight operations and things like that? There's also on the IBSC website, they have a CAMS guide, which I'm going to print out for everybody. Next week, I'm going to give it to you, which goes over more flight and ground considerations you need to know for the boards. So I'm going to print that out for you. You can take it home and study it before you take the board exam. And I just read through it once, and I did fine with everything.
Well, maybe he lied to you about the cocaine. Or sympathetic washout. We will get to that. Yeah, it could be like sympathetic washout syndrome is definitely a thing. So yeah, so sympathomimetic drugs, like just think that you're going to have elevated heart rate, elevated blood pressure. They're just going to be in a general state of hypermetabolism. Okay, like they're going to be jittery. Cocaine has the added effect if you do enough of it, and sort of methamphetamine. Methamphetamine has its kind of own set of problems, but it's not terribly uncommon. Somebody that has had enough of it, like near overdose levels, will actually have hallucinations on cocaine. So just be aware of that. That's always fun. So right here, so this is what the toxicrogram is going to look like. Increased heart rate, BP, diaphragm, flush, all the stuff that we just talked about, psychosis, and bad enough hallucinations. So just be very, very keenly aware of these patients. Make sure that you're keeping, don't let your guard down around them, especially with things like, it's not listed on here, but like PCP, for example. That is a very complicated drug. It's similar to ketamine. It's an NMDA receptor antagonist, but it's one of the hallmarks of that is they will go from everything is great, I feel euphoric, to like immediately being like incredibly violent, like right away. So when in doubt, like I said, just keep a close eye on these people. I'm sure Tyler can tell you, worked in the city, and have to keep your head on a swivel. Stimulant washout syndrome, just like Russ was talking about. So this comes from, like I have it listed here as excessive amphetamine use. That's sort of the typical presentation, but it can be from any over-abuse or overuse of these sympathomimetics. It's amine depletion. Amine, if you guys remember, like think monoamine, right? You think of like monoamine oxidase inhibitor. Monoamines are things like serotonin, norepinephrine, these like really needed neurotransmitters. And if you've just been redlining, like give me as much dopamine as you possibly can over and over and over and over again through drug use, eventually what you're going to run out of is this amine. You're going to run out of it. And then you're going to have the complete opposite. Like I was saying, like if you think of withdrawals as being, they're always the opposite of whatever the effects of the common drug of abuse is, right? So you're going to have the complete opposite. Like it's no longer. This is the the guy leaving the music festival Sunday night, and he can barely keep his head up, and he like wants to go home and shuffle himself loose the mortal coil. Like I said, he's going to go reach for the Tylenol PM. Excessive sleeping, hunger, depression, very common. And it's because they've depleted all of their amine and they cannot produce these neurotransmitters in adequate levels. So what are you going to do about it? It's largely supportive, but like I said, be careful. Remember that ketamine is a catecholamine reuptake inhibitor, okay? That's one of the reasons that ketamine has like such a, like you'll hear people say, oh, either ketamine won't mess with your blood pressure, or like, oh, it might raise your blood pressure. That's why, is it prevents the reuptake of her catecholamine. So whatever your catecholamine levels are that you have, ketamine is going to help you hold on to them, all right? So if they're on something like this, like let's say that somebody is, you know, took a bunch of, you know, they mixed a bunch of cocaine and MDMA together, you know, blasted a fat rail, and now they're just completely out of control, and you're like, well, we got to get this guy under control. Just be aware and know that if you give ketamine, like you could actually potentially make the patient's problem worse. And if you guys think about it, according to our clinical guidelines, if we're not giving it for pain control and if we're not giving it for drug-assisted intubation, the only indication that we have for ketamine really is excited delirium, which is a very specific thing, right? I mean, it's not just, oh, somebody is acting crazy, you know, whatever. That's excited delirium. Give them ketamine. You know, it's actually much narrower than that. Other things that you want to potentially avoid on Danzatron, so Zofran, right? You might be tempted, like if you think the patient's going to throw up. Why would I want to avoid Zofran in a patient who is experiencing a sympathomimetic like overdose? I think you said it. Prolongation of the QT, and you might have. We're more worried about it in the emergent setting. Is like we don't want to throw them into torsades. You know, so like if you have somebody who is, you know, again high on cocaine and their heart rate's already 180, and you're like, oh, I don't want them to throw up on my stretcher. I don't want to smell that, and you know, like you give them some Zofran, and then you turn around and they're in torsades, and then you have a whole host of other problems, right? So just be aware, avoid that. Haloperidol. And you know, some antidysrhythmics for the same reason. Like haloperidol also increases the QR duration, and so do a lot of our antidysrhythmics. So largely supportive, right? So benzodiazepines will help. Remember that we'll talk about what GABA is here. We'll do a review of that when we get to a later slide. But like benzodiazepines, you know, temperature management. If they do have the true excited delirium, we can give our ketamine, right? Serotonergic drugs. So these are antidepressants, okay? Our tricyclic antidepressants, our MAOIs, SSRIs, SSNRIs. The idea here, if you guys remember, you know, back like to how they used to classify depression as, oh, it's a chemical imbalance in your brain. I don't remember, I think that was born of like a pharmaceutical company's like commercials where they came up with that. But basically what we're trying to do is we're trying to increase the amounts of those monoamine neurotransmitters, right? We're trying to increase our serotonin, trying to increase our dopamine, trying to increase our norepinephrine. It's actually, if you think about it, like MDMA is basically a supercharged SSRI. Okay, that's why you get the euphoric effects. That's why everything feels great, and that's why you love everything, and everything's awesome, and everyone, you want to be everybody's friend, right? The idea is if like with an SSRI or an SSNRI, if we do that like on a smaller scale, we can just pull you out of being depressed, and you'll just no longer be depressed, and you'll be able to function quote unquote normally, maybe a little bit more typically, right? Several different options, okay? The monoamine oxidase, that is an enzyme that breaks down norepi, serotonin, dopamine, and another one called tyramine. The tyramine is not likely for it to come up in a test, but you may see the dopamine, serotonin, and norepi. Okay. Serotonin syndrome, increased agitation, restlessness, altered mental status, all of these things that you're going to see. Hyperreflexia, hyperthermia. I believe it's the muscle rigidity and the hyperreflexia that are going to be like the sort of giveaways that you have somebody who is experiencing serotonin syndrome. And then they might say something like, and a bystander tells you that they take an antidepressant, or maybe they've taken MDMA, and it can end up in this serotonin syndrome. Okay. What are we going to do about it? I forgot I didn't have a slide on this one. Very easy. Again, this one's supportive measures, cooling measures that are often going to be hyperthermic, IV fluids, and benzos for seizures. Typically, especially with some of our like SSRIs and SSNRIs, it is exceedingly rare that people die of overdoses of those particular drugs. It's why they've become so popular, and why they've kind of taken over TCAs. Like, we don't see TCAs quite as much as we used to because everybody is on an SSRI. And the reason being is because it's really difficult to kill somebody with one. You got to give a whole lot of it. Now, TCAs, tricyclic antidepressants. I remember in paramedic school, it's kind of like that John Mulaney joke where it was like, man, as a kid, I always thought that quicksand was going to be a much larger problem as an adult. Same thing with medic school. Like, I thought people were just going to be dying of TCA overdoses left and right, because it was like, man, this is always a problem, right? Huh? Oh, I'm sure there was and that's what I mean. Like, they've been taken over by SSRIs largely, so we don't really see this too much anymore. What's that?
Before they were egg
Yeah. So yeah, these are reuptake inhibitors. Like I said, like once you get a neurotransmitter like in your body either it undergoes a process called catabolism, or it gets broken down by an enzyme, or it gets it goes through a process called reuptake, where it's basically put back on the shelf. TCAs prevent that. Another thing about TCAs, and it's in the name of selective serotonin reuptake inhibitors, right? Like SSRIs, is these are completely non-discriminate. They're just going to prevent the reuptake of any and all neurotransmitters, which is a problem, right? Like, they also have a nice added little funness where they antagonize a lot of, they directly antagonize a lot of receptors, not the least of which being you have alpha, and you can have both alpha 1 and 2, M1, H1. Like, if you think about H1, like if we overstimulate the H1 receptor, like we can get like sort of like sleepiness. That's what, they can also bind to calcium channels, right? That's why when we look at, the whole, like, when again, back in medic school, at least when I went to medic school, and they would give you the TCA ECG, that is born out of the fact that this drug will just directly latch onto, what we used to refer to it as it would poison the sodium channels, but basically it just binds to it and just doesn't let go. So that sodium channel is now is useless. And if there's enough amitriptyline, for this example, in your body, it's just going to blockade all of your sodium channels, and that's very bad, right? If we remember back to our...
I'm sorry, what is amitriptyline used for?
Amitriptyline is it's a TCA. That is a tricyclic antidepressant. Really?
So, but I guess that's what I was asking for. So, like sleeping, or is it like a type of antidepressant?
It began life as an antidepressant. Okay. Like, probably the sleep aid, I would guess, is what they call an off-label use, okay, which is not what it was designed for, but it just found out that it was really good at it. Okay. So yeah, again, if you keep in mind, like, really the blocking the reuptake of the neurotransmitters is one problem that can lead to issues, again, like serotonin syndrome, but really, like, where most of the danger comes from TCA overdose is the fact that they can bind to all of those receptors, right? And it's very difficult to get them off, okay? This is your, like I said, classic TCA toxicity. We have very wide QRS complexes, okay? And it's because our sodium channels have been poisoned, right? They've been, and now everything's been nice and elongated, okay? So what are we going to do about it? If we have hemodynamic compromise, the drug of choice is norepinephrine, okay? Again, if you'll remember, one of the things that already binds to is the alpha-1 receptor, which is what we would want out of something like norepinephrine. But that alpha-2 receptor, did we talk about what the alpha-2 receptor does? Did we mention that? Just in general, what does the alpha-2 receptor do? If you stimulate alpha-2, what does that do? What does that produce? It's your off switch, right? That's your feedback mechanism to let your body know, okay, I've had enough. Like you can turn it off. Every time that your body produces, I'm sure Doc Tan mentioned this in endocrine, every time that your body produces a hormone or a catecholamine, like if it produces a substance that triggers or activates a receptor, right behind it is whatever shuts it off, okay? And in this case, it's alpha-2, all right? So even though it's like, well, Nate, you just told me it stimulates alpha-1, yes, but it also stimulates alpha-2 in equivalent numbers, okay? So even though like it is kind of hitting that light switch, it's also hitting that button that says shut everything down, right? So that's one of the reasons why it can cause that hemodynamic compromise. So you just overload it. You give more epi, like a lot of receptor manipulation, you know, with pharmacological agents is a lot of times it's just like, well, we have something that's blocking the activation. What do? We're just going to flood the body with more of whatever activates it and hope it overcomes whatever is stopping it. Okay, and this is an example of that. All right. Sodium bicarb for QRS widening. Remember, you're going to have to give that as an infusion. That's not something that you want to just give, you know, like pushing amps of bicarb on people. We do not do that anymore. We already know that, right? So that 1 to 2 milliequivalents IV. Again, that's only if our QRS gets above 100 milliseconds. That we can give that again as an infusion, okay? Mag sulfate for prolonged QT. C, we know this already. And then isopril for, or pacing for refractory torsades. Okay, so if we have a torsades that we can't get them out of it with mag sulfate, we've tried that, you're going to try the isopropanol or isopril, right? Avoid beta blockers. There is very strong evidence to support that beta blockers inhibit your body's metabolism of TCAs. So if you give a beta blocker, you're just keeping that drug in your patient's body for longer than it needs to be there. Okay, that's another sort of overarching theme when it comes to tox. I guess I probably should have put that at the very beginning, where part of the treatment modality for every single toxic exposure is try to eliminate the offending substance. Okay, do something about it, get them out of the environment. You know, like turn off the IV pump or whatever it is. Whatever it is that's causing your problem, try to remove that from the equation. Okay. Mm-hmm. It's not that dissimilar to like the overdrive pacing, like we talked about. But yeah, actually, you can. The idea is that you're going to use it in conjunction with your pharmacological treatment as well. You're going to give the magnesium to try to shorten your QTC, and if you have a torsades that just it won't like it won't come out of it, and you've like tried to like defibrillate them out of it, is that you can do the overdrive pacing to work to try to get that out instead. I'm unaware of any transcutaneous device that's capable of doing overdrive pacing. No. Monoamine oxidase inhibitors. Again, so when we're talking about our antidepressants, which is like where we're at, what we're trying to do is we're trying to augment or increase the amount of these neurotransmitters. And like we talked about previously, the monoamine oxidase helps get rid of those neurotransmitters, right? So with the inhibitors, you know, common example like Nardil, Parnate, these are some things that you might see their MIOIs. I don't know how common they are, honestly, anymore. I think mostly really what we see are just SSRIs. TCAs are still around because there are some people that for whatever reason can't take an SSRI. Maybe they're allergic to something that's in it, or maybe they had an adverse reaction to it. It's much more typical that they would end up on a TCA than they would one of these, okay? This is one that's going to cause serotonin syndrome. And like I said, initial stage, sympathetic hyperactivity, neuromuscular abnormalities, followed by central nervous system depression, cardiovascular collapse, okay? These two, the TCAs and the MAOIs, are the most lethal classes of antidepressants. These are the ones that are most likely to kill. That doesn't necessarily mean that they're super lethal, although TCAs are considered to be like probably the most dangerous ones. MAOIs, they end up with a similar result as TCA because it's not really, it doesn't discriminate, right? It's going to have increase all levels of these neurotransmitters. The big difference is that MAOIs don't directly antagonize any of the extra receptors like TCAs do. Okay. SSRIs, for treatment, there's no specific antidote for an MAOI, and the treatment is going to be, again, this is another one where it's going to be largely supportive, okay? There's not really anything specific that you're going to do for MAOIs. Okay. So yeah, your selective serotonin reuptake inhibitors and your selective serotonin norepinephrine reuptake inhibitors, that's what the SSNRI is, are, again, very seldom lethal. We're not really super worried about these guys in terms of direct, like, emergent response, okay? Fewer side effects. I always think the last bullet point, I always include this one because it's really silly that it's like, it increases suicidality in younger patients. And like, we don't really have like a great handle on exactly why that is. We don't really know. But yeah, I always just thought that was funny. It's like, oh, a 14-year-old thinks that the one that wants to kill themselves, I'll give them an SSRI. What could go wrong? They can cause QTC prolongation, but again, it's very, very seldom. QTC prolongation is going to be the same. Just you're going to treat that with magnesium, like the same standard magnesium guidelines that you would previously. Antipsychotic drugs. So antidepressants are centered on our goal with an oh, lost my notes. Here we go. Our goal with an antidepressant is to increase levels of our various neurotransmitters. Antipsychotics are the opposite. What we're trying to do is we're trying to decrease those levels. Okay, they have too much. There's too much going on, and we need to do something about it. They're commonly referred to like in generations. Okay, that's going to become important. That distinction is an important one. So our first gens, they inhibit dopaminergic neurotransmission, specifically the D2 receptor. Okay. They have a secondary effect of blocking catecholamine and histamine receptors, okay? The catecholamine we're thinking about is norepinephrine. So it actually can just straight up block norepi from being able to do its thing, all right? Adverse side effects, low-level anticholinergic syndrome symptoms. Sedation because of the H1 stimulation, or the blockade of the H1 receptor, and orthostatic hypotension. The orthostatic hypotension is how the norepinephrine blockade is going to manifest. Okay, it's like they're going to have orthostatic hypotension because they don't have the ability to use norepinephrine like you or I would, right? The second gen ones also block serotonin, so they function just like the first gen ones do, but they have an added effect of blocking serotonin. Okay. Extra pymyridal syndromes. Can somebody tell me what like the most common one of those that we're taught about is? Dystonic reaction. Dystonia. Yeah, dystonic reaction. You're going to treat that with the actual treatment for an for a dystonic reaction is an antimuscarinic. However, we don't carry an antimuscarinic, but we do carry an antihistamine. And like we discussed previously, our muscarinic receptors are very, very similar to our histamine receptors, which is why you treat dystonic reaction with Benadryl, in case you guys were wondering, right? It targets a different receptor. So it is an antimuscarinic, but remember we have 5 antimuscarinic, and really the ones that we're looking for are the muscarinic receptors that are in the central nervous system, and that's what histamine. That's actually a good question. I guess that would be an important distinction to make, is that the histamine receptor is more similar to our muscarinic receptors in the central nervous system.
1, 4, or 5, or 1?
I think, look at the slide. I can't remember off the top of my head.
So even if we did carry the anti-muscarinic, so
Oh, probably what, trihexylphenidate, or the ones that we would use for benzotropine and trihexylphenidate, the ones that we would use for Parkinson's disease. Those would be the ones that you'd want to use for, yeah, benzotropium is probably the more common one. Although trihexylphenidate is a newer drug, so that one might be, but yeah, that's what you would use for, good question. Cool. So, and as far as like typically those are the what we're going to see when we reach toxic levels are going to be like the sort of the worst manifestation of it is going to be that dystonia, that dystonic reaction, and that's where we're going to get it. That's actually why the serotonin, like the second generation ones, have the added effect of blocking serotonin, is because you're much less likely to see dystonia if we also blockade serotonin. Neuroleptic malignant syndrome, okay? So both the first and second gen antipsychotics can cause this, okay? These are going to say high fever, diaphoresis, unstable blood pressure, altered mental status, the muscle rigidity like we talked about, and autonomic dysfunction, okay? It is secondary to a dangerous decrease in dopamine. We've lowered their dopamine too much. We do need some of it, right? I mean, it is an important thing to sustain life, okay? So sometimes dopaminergic drugs will be prescribed along with these antipsychotics, all right? And really what they'll do is they'll kind of start with the antipsychotics, see what happens, kind of figure out like, okay, we have a pretty good handle on how much dopamine's being blocked here, and then they'll introduce the dopaminergic, because really what they want to do is they want to get them to like a nice sort of healthy, again, quote unquote, lack of a better term, normal level, okay? So autonomic dysfunction, we're talking about things like orthostatic hypotension again, sexual dysfunction, decreased ability to sweat, elevated blood pressure while lying down, right? So again, orthostatics, and changes in gastrointestinal and urinary habits. So they may need to go to the bathroom more often. Okay. Salicylates, aspirin, certain antacids. Okay. So aspirin, these drugs, they inhibit the COX-1 enzyme. Okay. That reduces inflammation. At least that's how that's where the analgesic properties of aspirin comes from, is inhibiting that COX-1 enzyme, okay? It works as an antiplatelet by blocking the action of thromboxane A2. And secondary effect is direct stimulation of our medulla, specifically the respiratory center of the medulla. So again, this is another one that we should be very familiar with, okay? This is going to cause an acidosis, right? And then it's going to cause, so we're going to already have an acidosis in the body, and then we're going to have direct stimulation of the medulla. So, which brings us to our next slide. Specifically, it's a high anion gap acidosis. I'm sure, unfortunately, I apologize, I wasn't here to help him out with it, but I'm sure Brian did a wonderful job when he talked about advanced ABGs and your anion gap. Okay, so this is something that can cause that high anion gap metabolic acidosis. All right, causes a respiratory alkalosis, but again, we've directly stimulated those respiratory centers in the pons, I believe, is the specific area. So like the patient is going to be breathing really, 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 really fast, okay? Increase in cerebral glucose consumption. So paying attention to these folks, pay attention to their blood sugar is very important. It's very likely that you're going to have to, at one point or another, you're going to have to supplement their blood glucose. Okay. I don't know if we talked about all that, so we'll skip that a little bit. Okay. Yeah, but see, you are going to have, like I said, a decrease in your serum glucose. Mild symptoms, again, the tinnitus, dizziness, lethargy, nausea, vomiting. Severe, that's when we get into the tachypnea, like we talked about, along with the high anion gap metabolic acidosis. Your labs are going to be not great. Hypothermia, coma, cerebral edema, eventually death if we don't step in and do something about it. Okay. It says avoid intubation unless it's absolutely necessary for the reason that we talked about. Our mechanical ventilators are not going to be able to keep up with how fast they are breathing. We're talking about 60 plus times a minute breathing. Your ventilator's going to have a really hard time with that. So what we're trying to do is, again, we're trying to get rid of the offending agent. How we get rid of the offending agent in this particular case is going to be hemodialysis. Okay, we're going to actually try to get this, directly clean this out of their blood, and then the same thing, a sodium bicarb infusion. Okay, this is not one that has, again, a direct, what we would call an antidote, or what we consider to be an antidote, right? Any questions on salicylate toxicity? How did we do with our advanced ABGs? We feel good about that?
We haven't tested on it.
Very good. So the jury is still out, says Donnie. Okay, cool. Acetaminophen. Okay, Tylenol, very common. I feel like acetaminophen is in basically everything because in its oral form, it's very inexpensive to make. This is one of those lovely drugs that you've heard me talk about a handful of times, like when we did epilepsy and seizure treatments. We know that it also inhibits the COX-1 and 2, so its analgesic properties is very similar to aspirin. However, we're not exactly sure how it works. We know that it does, and like I said, often complicated by the addition of other drugs. Most commonly, either your opiates, so it's very like Tylenol 3s, right? If you guys remember Tylenol 3s, or like a Tylenol PM, something that has Benadryl in it. Okay. And like it says, this is just a trivia question. I don't know if you're going to see this on a test or whatever, but yeah, this is the most commonly overdosed drug in the United States, which is horrible to think about because it is neither a fast nor comfortable way to kill yourself. It is not. Okay. They talk about it in stages. So again, stage 1, broken up in 4 stages, 1 to 30 minutes, up to 24 hours. Could be completely asymptomatic or prevent only with emesis, right? When we get to stage 2, we're definitely going to have emesis, right? They are going to start throwing up. This is where they're going to have the right upper quadrant pain. This is when your blood pressure is going to start getting affected, okay? Stage 3 is basically, again, if we don't intervene, and we'll talk about here in a minute like what we can do to intervene here, but stage 3 is kind of like, as you can see to stage 4 or whatever, you either make it or you don't when you get to stage 3. And it's just, it really all depends on how quickly did we identify that acetaminophen was the offending agent and how quickly were we able to intervene, okay? That's when we get but yeah, stage 3, 72 hours to 96 hours is when we get liver dysfunction. Yes?
On the boards, I had a stage 3 question, and it's important to know that liver function tests will peak on stage 3 for your boards.
Right. Yep. I don't know if I'm, okay. Yeah, very good. Yeah. Oh, yeah. Last one here. Liver function test will peak. This is where you're going to get the worst, and then it'll start to go down. And like I said, death is most common in stage 3. Okay. If they make it to stage 4, 4 days, 3 weeks, whatever, is marked by recovery. However, you have done irreparable harm to your liver. Like these people's liver, like your liver is an incredibly resilient organ, and it's very, very good at healing. However, if you have overdosed on acetaminophen, like that is permanent liver damage. It's just, you're never going to get better from it. What do we do about it? Glad you asked. So this is something called acetylcysteine, or you can just call it mucomist, because that's what it's called, okay? This is the only approved antidote for acetaminophen, okay? So this one is definitely going to show up on your test, right? Like, what is the antidote for Tylenol? Again, if you want to be easy about it, call it mucomist. If you want to be technical about it, acetylcysteine, I think I'm saying that right. I'll have to consult Google later, but this is the generic name is what you're more likely to see on an IBS-C test, okay?
How do you spell the other one, the one that starts with M?
Mucomist is M-U-C-O-M-Y-S-T. It's called mucomist because when you can get it, I don't know if it's over the counter, I think it has to be prescription, but you can get it in a nasal spray, and it's for like clearing up your sinuses, hence mucomist. However, when you give it as like in this form, it produces an increase in a substance called glutathione, and what it does is it neutralizes the toxic metabolite of acetaminophen, okay? Like we talked about previously, a lot of the times, and we're going to talk about this more a little bit later on, a lot of the times the thing that kills you isn't the drug itself. What kills you is what your body turns it into, okay? So if you can prevent your body from metabolizing a substance when we get to toxic alcohols, like we'll talk about that in much greater depth, you can basically just render it inert, you know, because and then it'll just pass through your body and you'll eventually secrete it, you know, either through your urine, your stool, whatever, and it'll no longer be a problem, okay? If this is given within 8 hours, like the last one, this is important, which I said, like time is very important here. 100% protection from liver damage. All of the other things that happen to you, like this sort of GI upset and all the unpleasantness, will still be present, but it will massively increase your likelihood of surviving it, and your liver will be plenty healthy on the other side. Like you'll come out and your liver will be just fine, okay? If given within 8 hours. So on to some more kind of fun ones. So this next like 3 drugs that we're going to talk about, or 3 drug classes really, we have like some sort of exciting things that we're trying, but a lot of times like, well, we'll get into it. You guys understand what beta blockers are, okay? It's going to blockade the the beta 1, beta 2 receptor. I don't know if it has any effect on the beta 3 receptor, but if it did, it's not going to matter. I know that in high enough, like it says here in this third one, which is important to note just with beta blockers in general, is when we say that we have, like for example, we talk about albuterol, you know, being a beta 2 antagonist, right? But we also know that it has some spillover effect. You know this intuitively because what's a side effect of giving somebody albuterol? Increase in your heart rate, okay? You can't have an increase in your heart rate if you're not stimulating the beta 1 receptor, okay? So just because it says, oh, it's mostly this or it's selective to this, there's always going to be some spillover, and in high enough doses, the selectivity is lost entirely, okay? And that doesn't matter. Like if it'll just start attacking everything. Lipophilic or lipophobic is important. The distinction between these two is important because one of the things that we can do for not just beta blocker overdose, but a few others that we'll talk about, is something called high lipid emulsion therapy, where they will infuse a person's body with a solution that has a bunch of fat in it. And the idea is that it's going to, if it's lipophilic, it's going to want to attach to that fat molecule and not get metabolized by your body and just get flushed out, okay? So that's an important distinction that they'll ask. It's not important for you guys to know if metoprolol is one versus carvedilol, you know, like that's not important. But just know that this distinction exists because of one of our treatment modalities. So it is a question that we're going to need answered eventually, okay? So if we blockade all of our beta receptors from being able to do their job, you know, like what are we going to get? Obviously bradycardia and bradydysrhythmias, hypotension, bronchospasms, pulmonary edema, you know, seizures, altered mental status. They can be normal or hypoglycemic. Why is that in red? That's important because another overdose that we have is that's very, very, very similar is going to, this is going to be the thing that's your differentiator, okay? So if you have somebody that overdosed on their heart pills and you don't know what they are, and they have all of these symptoms, but their blood sugar is normal or their blood sugar is high, think beta blocker toxicity. Or sorry, low, yeah. Normal or hypoglycemic, yes, sorry. Listen to the slide, not me. Normal or hypoglycemic, think beta blocker toxicity, okay? Treatments are listed here. Sodium bicarb if the QRS is wide, mag sulfate if the QTC is prolonged. You guys understand those things intuitively already. Does anybody know why we use glucagon in beta blocker toxicity? Did we talk in great detail about what glucagon does? Okay, well, it doesn't work for one thing, but the idea behind it is one thing that we know glucagon does is glucagon increases something called adenylyl cyclase, okay? What an increase in adenylyl cyclase does will then cause and this is intracellularly, sorry, that's an important distinction to make, intracellular adenylyl cyclase. What that does is it increases something called CAMP, cyclic adenosine monophosphate. You guys know what that is? Did we already talk about that? Okay. So we know that if we have increased levels of CAMP, it'll lead to like increased FRAC, right? Specifically in the heart. Like, so we can get sort of, because we know that if we stimulate the beta-1 receptor, what that does in your body is increases intracellular CAMP levels. So the idea is we're going to use glucagon, we're going to bypass that beta receptor, and we're going to just directly increase levels of CAMP inside the cell. Like Tyler pointed out, though, it's a wonderful theory. We know that the drug actually does that. However, it's not borne out in evidence that giving somebody on a beta blocker toxicity a whole bunch of glucagon actually really does anything. Granted, it's still an answer on a test, right? Like we're still going to see this. Like I said, you might see that on your IBSC board exam, but just don't be, a very sad face if you have a patient who's like, oh, they have a beta blocker overdose, and we loaded them up with glucagon, and they're going to survive, and then they die. It wasn't your fault, okay? High-dose insulin. What high-dose insulin can do is it can so giving high-dose insulin in these particular patients, what it can do is essentially optimizes your heart's myocardial function, okay? Like through like a number of mechanisms. When I taught this last year, I taught something previous to it where we explained a lot of stuff that we actually decided that was just clogging people's brains up and we didn't need to know, but just know they'll give them a high-dose insulin. We already talked about the lipid emulsion therapy. What it can do is basically we flood their body with this fatty solution, and it's going to hopefully get the beta blocker, like whatever the drug is, to attach to it, as opposed to metabolizing in your body and then get out. ECMO is probably their best shot, honestly. So which ECMO, which version of ECMO would you think I would use in these patients? VA ECMO. Okay, you're going to use VA ECMO because what we're doing is we're trying to help augment cardiac function. Okay, your lungs are fine. Your lungs are okay. They're probably working, just fine or whatever. But what we need to do is start circulating blood through the body because your heart's not going to be able to do it. Okay, because you've turned off all of the, your body's pumping, hey, but here's all this epi, do your thing. But because you're completely beta blockaded, it's not going to work. Okay. I'm sorry? It will not help. It will not help. And that's kind of the thing about beta blocker toxicity, calcium channel blocker toxicity, and sodium channel blocker toxicity. We talk about these treatments, ECMO being one exception to this because we're literally mechanically kind of bypassing the function of the heart, right? But as far as like all this other stuff, basically, like you overdose on these things, you're probably just going to die. As sad as that is to say. So calcium channel blocker toxicity, okay? So it's going to present almost identically to what beta blocker toxicity is for obvious reasons. The difference is they will be hyperglycemic, okay? So if you see somebody overdosed on their heart pills and they're bradycardic, they're hypotensive, maybe bronchospasm, maybe pulmonary edema, altered mental status, seizures, but their blood sugar is 350, you know, and they're not a diabetic, think calcium channel blocker, okay? Think calcium channel. That's going to be the distinction. And these are going to be the things that, you know, again, that they're going to pop up like on your test is they're going to give you these. Like I said, they never just tell you what the drug is and ask you, or tell you what the offending agent is and ask you what the antidote is. They're just going to give you a set of signs and symptoms, okay? So what are we going to do about it? So calcium can be trialed for the same reason that we discussed earlier, where like a lot of what our pharmacological agents, our goals are, is we've identified that something is being blockaded or something is being, you know, otherwise disallowed from happening. And so what we're going to do is, well, all right, we'll just flood the body with as much as we possibly can to hopefully overcome. Like it says in the slide, it's dubious whether it's going to actually have an effect. You still try it. It's definitely not going to hurt the patient unless they're to the point where they have multi-organ failure or multi-organ dysfunction, especially with something called tubular necrosis or hepatic necrosis. Those two are not super duper high yield, like for a test or whatever, but just know that if you have these things, over administering calcium and a calcium channel blocker toxicity, where they're basically where their kidney or their liver is found to be necrotic, it can actually make the problem worse. Okay, methylene blue. Do you guys remember methylene blue from our? Say it again. Yep. So well, that and also it's used as that. That is one. What else is it used for? Very good. What did you say? Nitrate overdose. Very good. Well, it can also be used. It is very uncommon, but it is also a vasopressor. Okay, this can also be used as a vasopressor. Yep. And that in this case, that's what this is. Like I said, it's quote unquote bypassing the calcium channels, specifically the ones in your arteries, to counteract the vasoplegia. Okay, because we have two different kinds of calcium channels in our body. Okay, we have dihydropyridine and non-dihydropyridine calcium channels. That's why we can have a calcium channel blocker that works on your heart and then a calcium channel blocker that works on your vessels. But just like with beta blockers, if we have a whole bunch of calcium channel blockade, that selectivity can be lost. And we can have effects on both the heart and the vasculature, okay? If that happens, trying to give something like norepi for this isn't going to work. We're going to have to use something like methylene blue, all right? It's actually kind of cool. It uses a very so there's like you stimulate a receptor, and then there's a cascade of events that happen that have a resulting effect or whatever. And a lot of things that we have, like vasopressins like this, like if you give exogenous vasopressin, it doesn't stimulate the alpha receptor, but after about 2 steps, it's completely identical as far as like what it does to the body. Methylene blue is very similar. Okay, you can try catecholamines if you want. To what extent they use is unclear, and that this word being plural is very purposeful. Okay, because you would want to build, like a pressure package, as they say. You're going to want something that is going to increase frac, all right? Because like I said, you're going to have the calcium channel blockade in the heart itself, and then you're going to want to have something that's going to work directly in the vasculature as well. Okay? No, because it's doing different things. So methylene blue bypasses the calcium channels in the arteries, whereas with beta blocker overdose, what's being blockaded is your heart's ability to react to things like epinephrine. Okay, so it's a completely different. In beta blocker overdose, your vasculature is fine. Like, and it's actually probably going to be squeezing like all hell to try and counteract what's happening. You're going to have like the massive decrease in frac, right? So your force rate, automaticity, and contractility.
Like they're different receptors, so that's why.
They are different receptors, yes. Yeah, very good. Well, this is a ion channel, but your beta 1 is a receptor, but it acts in different areas of your body. Okay. Also, high dose insulin and lipid emulsion therapy. Okay. Sodium channel blockers. All right. So we already know what sodium channel blockers do. Okay, like your lidocaine, your cocaine. We saw the sodium channel, or the what's it called? TCA ECG earlier. That's going to be extremely similar to if we have a true sodium channel blockade, right? So anything that ends in cane, right? Slows, decreases, movement across the sodium channels. These drugs can cause a comorbidity that you got to be on the lookout for are disorders of sodium channels, right? So if you have long QT, short QT, Brugada's sick sinus syndrome, if you have a patient that has one of those comorbidities, they are extremely sensitive to sodium channel blockade overdose, like what would be maybe a normal, totally healthy dose for somebody without those disorders could easily be lethal for somebody with those, right? Sodium channel blockers can cross the blood-brain barrier, right? Inhibiting GABA receptors, H1 receptors, okay? Who can complete this sentence for me? GABA is your body's primary what? You guys remember that? Does that sentence sound familiar? I know I've said it to you at least once when we talked about our No, this is actually, how do you say it? It's a very long word. You have a GABA receptor. GABA refers to the substance, okay? It refers to the actual neurotransmitter that antagonizes this receptor. But do you remember what that is? GABA, it's the body's primary inhibitory neurotransmitter. Okay, write that down. It's important. It's your body's primary inhibitory neurotransmitter. That's why when we give GABA antagonizing drugs, or agonizing drugs rather, like benzodiazepines, we get central nervous system depression. We get, sedation, essentially, okay? So if I inhibit my GABA receptor, what would then happen? No, I'm inhibiting it. Yeah, the opposite. The opposite effect, okay? Block the action of norepinephrine as well. Okay. So unfortunately, there's no like hallmark symptom to sodium channel blocker toxicity like there is with beta blocker and calcium channel blocker. Which kind of sucks, right? But they're going to present slightly differently. These patients are the ones that are going to be complaining of chest pain, the cocaine chest pain, right? That cocaine chest pain comes from the fact that cocaine is a sodium channel blocker, okay? Because if you guys have ever seen that one. I actually had a guy, very, very, very short story, that admitted to smoking crack. I saw what I thought, I was like, this has to be pericarditis because I had elevation everywhere in my 12 lead. Turns out the guy actually had 100% occlusion of his right coronary artery, and his left main was fully occluded secondary to coronary artery spasm from sodium channel blocker overdose. So he actually was blocking everything. Half of it was all of it was because of poor lifestyle choices. But half of it was because of prolonged poor lifestyle choices, and then the other half was because the guy was high on crack. He died, yeah. That was one of the ones where I walked in and the first thing that the ER doc asked me was, did you give him aspirin? And I literally was like, well, considering I just told you I defibrillated him twice, no, I didn't. I'm sure you can give him some Brilinta or something and he'll be just fine. Yeah. ECG changes, morphology changes. Obviously, you're going to see widening of the QRS. Okay, so we remember that first part of the cardiac action potential is the fast sodium channels, and that's represented by that straight line moving up. Well, when we blockade sodium channels, like we talked about with the sodium channel blockers, I don't know if I was here and if I mentioned it with this group or not, but did you guys hear me say the salty cab drivers? Right, it's because you have on that class, the sodium channel blocker class of anti-dysrhythmics, you have C, A, and B, okay? And that is the order in which, like how profound it's going to alter that phase of your cardiac action potential, right? So you'll see widening QRS, QTC prolongation, new onset right axis deviation, Brady dysrhythmias, VTAC, VFib, Torsades. So phenocopy Brugadas. So Brugada we know is a genetic disorder, right? Like that's how we typically think of Brugadas is like they have a gene mutation. Which gene it is escapes me at the moment. Phenocopy, what that means is that they will actually develop Brugadas, like you'll see Brugadas on their ECG, but they do not have the gene malformation. It's because of they're overdosing on a sodium channel blocker. It's a fascinating thing.
So that would be like SCCAD too, right? The phenocopy?
Say that again.
SCCAD can cause Brugadas.
What are you talking about?
SCCAD, like with the anti-ADH.
Excessive ADH.
It can cause Brugada.
Oh, yeah. Sorry. SIDA. Like, I always refer to it as SIADH. I haven't heard anybody refer to that. But yes, very good. Like that is that they do not have the gene malformation, but due to another factor, they can develop Brugadas. Yeah, very good. Sorry, I was like cider. I'm like not that I know of. I mean, I guess if you drink enough of it, maybe it might. I don't know. Very good. And like I said, coronary artery spasm, not super common, but it'll present exactly like an MI, just like that lovely fella that is no longer with us. He was only like 38 too. It's crazy. What are you going to do for sodium channel blocker toxicity? You're going to do the sodium bicarb. You're probably going to have to build yourself a nice pressor package like we discussed with the calcium channel blockers, where we're going to have probably something to support our frac, and then probably something that is going to be vasoconstrictive in nature. Okay? Benzodiazepines if you're seizure, lipid emulsion therapy if necessary, and again, ECMO if it gets bad enough. The treatments work better for sodium channel blocker toxicity than they do for beta blocker or calcium channel blocker. So this is actually going to have a better prognosis than those other two. But it's still lethal, obviously.
What's that, a liter of V5? Where do you get a liter of V5?
No, this is 2 to 3 amps in 1 liter. Oh, wait.
Yeah.
Where do you get that at?
They carry them at the hospital. Yeah. You can get all different sized bags of fluids in the hospital. You've never seen the 5 liter bags of like, oh yeah.
Remember we talked about this last week, we mix sodium bicarb in water. We do not mix it in an S.
Yeah.
So keep that in mind, T5W or T5 is what we're mixing it. So we don't give sodium bicarb infusions necessarily in the field because we don't carry T5.
Yep. Also, to answer your question more pointedly, Tyler, it wouldn't be inappropriate, like if all you had were like 500 bags, just like divide the amount of bicarb that you put in there and just use a 500 bag. So
the protocol we have for normal saline, you should just ignore that.
No. Do we have a protocol for sodium bicarb infusion?
Yeah.
And it says put in the normal saline?
Yeah.
Well, then do it. I mean, but you should.
you really shouldn't. Yeah.
Practice has been loaded in water because of the hypertonicity of the sodium bicarb in a sodium chloride solution.
Yeah.
Sodium bicarb infusion, 100 to 150 millicubics versus 1,000 mils of normal saline.
Well, but 150 millicubics isn't the whole amp. You know, how many millicubics is an amp?
No, isn't an amp 50? Yeah. Yeah, Brian makes a good point because then you're so you know how in the sodium bicarb it has a percentage of what it is? Well, like it would throw that percentage off because you're just adding a whole bunch more sodium into it.
It's an overdose class ingestion protocol.
may be an
Really?
overlook. And we may have to revisit.
Yeah, it's too bad Dr. Tan's not here, because he'd be able to answer that more pointedly. Yeah.
We just had the update. We can't get another one.
Brian, how long have you been working here? How many times have they given updates to the? Happens all the time. Like we get protocol updates all the time. It's probably not going to do a great deal of harm, but yeah, like it's important to keep a handle on. I guess the answer to that then would be you're just going to draw regular labs and just keep an eye on their basic metabolic panel, just to make sure that you're not getting to the point where, again, like if I rapidly increase or rapidly decrease my sodium levels, like it's not good. You know, like I said, we want to have like fairly tight control over that, right? Probably not, honestly. So. Cardiac glycosides. So digoxin, right? So digoxin acts a little bit differently to achieve our therapeutic effects, right? And then subsequently our toxic effects. It actually directly inhibits the sodium-potassium pump, right? Increased intracellular sodium levels leads to reversal of function of the sodium-calcium exchanger. Leads to an increase in intracellular calcium. So the sodium-calcium exchanger, we're very familiar with the sodium-potassium pump, right? We talk about that one all the time. However, there are plenty of other of those little ligand-gated ion channels, as we call them, that are responsible for moving other electrolytes just around your body, in and out of the cell. Okay, like one example of that is the sodium-calcium exchanger. Okay. Anyway, so what that does, like if we reverse the function of the sodium-calcium exchanger, which would be to put calcium outside of the cell, excuse me, what that does is lead to increased levels of calcium in the cell and increased inotropy, right? Which is why we give digoxin for heart failure. Okay. It can also increase vagal tone. Yes. Oh, sorry. You know, making it very helpful for tachydysrhythmias as well. Okay. Signs and symptoms. We're going to have visual disturbances. This one I should have made red, but the yellow-green visual disturbance is the hallmark symptom of a cardiac glycoside overdose. If this ends up being the substance that they're trying to lead you to, you're going to have this yellow-green discoloration. Okay, and they're just going to see everything is just going to have the kind of a yellowish-green hue to it. Okay, palpitations, difficulty breathing, you know, hyper-K, bradycardia, general weakness, you know, AMS, acute mental status. Okay. Digifab or digibind deactivates digoxin, so that actually is an example of an actual antidote or reversal agent, as it were. So again, highlight this one. I should have made these two red as well. Yeah. So the digifab or digibind. So if you have somebody altered mental status, complaining of palpitations, you know, dyspnea, slow heart rate, you know, having trouble standing up. With the yellow-green discoloration, and again, like I don't know, like I think he took too many of his heart pills. This is what they're leading you to, and you're going to say, "Awesome, here, have some digibind, sign here, AMA." Not really. This is the example of what we would see with a digoxin ECG. We have depressed. ST segments, thank you. So, bradycardic, an example of what we might see with a digoxin overdose. Okay. Opioids. So everybody's familiar with opioids, right? They directly agonize the opioid receptors, you know, causing pain relief, you know, euphoria if you're not in any pain. We all know that Narcan is the is the correct or is the reversal agent. I'm big on this one. I don't know about you guys. Like, I'm not a huge fan of like, oh, he's an overdose here. Here's 4. Let's wake you up and have you cuss me out and walk away. Like, I'm personally not a huge fan of that. I would much rather like let's like kind of gradually bring you out of this. Where it's like, and I do believe this is still in the protocol of diluting it. Like taking the like just like you would a epi 1-to-1, where you take 1 milligram of this and put it into mix it in with 9 cc's, and then you can give it in 0.1 milligram increments, and gradually and like more gently bring somebody out. What's up?
I was gonna say where I came from, we have 0.4 milligram vials.
Did you? That's awesome. I wish, yeah, because
I loved it so much.
Yeah, it's so much easier, right? Narcan can be used as an infusion if your overdose is severe enough. Like if they were a huge Velvet Underground fan, or if they were really dedicated to the shuffling themselves loose this mortal coil, and they gave them, and they have a ton of it in their system, you absolutely can run it as an infusion. The opioid syndrome, again, very easy. The hallmark symptom here is pinpoint pupils, but then altered mental status, depressed respirations. You guys are all very, very familiar with this. Oddly enough, like if somebody is withdrawing from opiates, the hallmark symptom of that is yawning. Okay, if you ever see a question about somebody yawning, and like a way that you can remember it is the opioid ooze. Like they'll yawn excessively. It's weird. Benzodiazepines, GABA agonists. What was GABA again? GABA is the body's primary what? Inhibitory neurotransmitter. Very good. So if we want to get those effects, we have a synthetic drug here that is going to directly agonize that receptor. Okay? How it does that is it increases intracellular chloride. If I have more chloride inside the cell, is chloride a negatively charged or a positively charged ion? Negative. So if I increase intracellular levels, what does that do to my action potential? Raise that threshold. Very good. Okay, reduce LOC, sedation, respiratory depression, hypotension. It works very similarly to barbiturates. Does anybody know the distinction between how a barbiturate works and how a benzodiazepine works? Because they both affect chloride channels. So a benzodiazepine affects how often a chloride channel opens and closes. A barbiturate affects the duration of a chloride channel being open, or in this case closed. An easy way to remember that: Ben wants it to happen more often. Barb wants it to last longer. Yeah. So there you go. Thank you very much. I'll be here all week. We all know that the reversal agent here is romazicon or flumenazole. That directly counteracts the actions of benzodiazepines. We don't see them in the pre-hospital setting. Why don't we see them in the pre-hospital setting? Yep. It may cause refractory seizures. This is another thing that's very important. A very important distinction to make is that people who are benzodiazepine addicts, a hallmark of withdrawal from benzodiazepine is seizures. And the weird thing about that is that it can happen up to weeks later. Like, you can literally be like somebody who was abusing benzodiazepines. They stopped, they got clean. It's 3 weeks later, and they are having an uncontrollable seizure. And it's because their body is still in benzodiazepine withdrawal. Okay?
I got a question on this. It probably does not matter at all. But does based on how GABA works and bring chloride and then make it more negative, does it raise the action potential threshold, or does it just take you down further negative, which makes it a longer distance to get up to that?
That's kind of a difference without a distinction, or a distinction without a difference, because technically what it does is raising the action potential. If you want to get even more, I guess, specific about it, it is increasing the amount of stimuli needed to like activate the or to achieve cell activation. Does that help?
Yeah, it just sounds like it takes you more negative, but it's not like it matters.
I mean, you're not wrong. Like it makes the inside of the cell more negative, and like when we remember, like again, like the easiest example, because it's one everybody's most familiar with, is the cardiac action potential, where how it starts out at negative, and then it shoots up to positive. Okay, so if you think about it like in your central nervous system, and we think about the same type of action potential, right? It'd be like instead of starting out at it would be like, okay, now that we've agonized our GABA receptor, well, now we're at negative 130. So it's just going to take that much more to overcome to actually like, okay, now I've activated this cell, and now it's doing what I want it to do. Okay? So yeah, that is your reversal agent, your Razcon, your flumazenil. Again, another one I'm not really sure if I'm saying properly. Now, one of the fun ones, toxic alcohols. We have 6 substances that we're going to have to discuss here, okay, that all fall into the toxic alcohol category. And yes, ethanol, the one that I'm sure no one in this room has ever tasted, is technically a toxic alcohol, okay? They are classed as protoxins. So I know I'm pretty sure I talked about prodrugs when we talked about our anti-seizure medications, right? So a protoxin is sort of the same thing, right? Which in and of itself, any of the substances that we're talking about are actually not bad for you. They won't harm you. It's what your body turns it into that is harmful, okay? It's when your body metabolizes it, that's when it's going to cause potentially death, right? All alcohols will cause a hyperosmolar state, okay? That's actually why when you get drunk, you pee a lot. It's not because like you are constantly taking in more fluid than you normally would. You're actually altering your body's serum Oz, okay? That's why you pee more.
I thought it was inhibiting ADH.
Well, it also does that, but yeah. So, yeah, it does both. Yep. Anyway, so alcohol dehydrogenase. This is what is going to cause, it's what's going to metabolize our toxic alcohols, our alcohol into the toxic substances, okay? They all are going to bind to the GABA receptor. That's why people put them in their bodies, is because it's going to, when we get to ethanol, we'll talk about it a little bit more specifically, but they're all going to cause CNS depression, okay? So the most toxic one is methanol, okay? It is the chemically simplest one, and this is the one that is the most toxic, the most lethal, okay? It's the simplest form from a chemical point of view. This is what pops up when you have poorly distilled moonshine. I used to work with a guy who, I used to say that his family was from Charlotte, he was from North Carolina. Because he was a barefoot hillbilly, and he gave me a whole lesson on how when you shake the bottle and you watch the bubbles and how big the bubbles are, and then you light part of it on fire, and what color is the flame, that lets you know whether or not you got good shine or if you're going to try and drink some methanol, okay? It is metabolized into formaldehyde and eventually formic acid, both of which are very bad to be inside of your body. You don't want any part of that. The hallmark symptom of methanol are your visual disturbances / blindness. This is, again, where you hear like, oh, somebody drank moonshine and went blind. Well, this is why, okay? When it's metabolized into formaldehyde and eventually formic acid, what do you think that's going to cause inside of your body? I'll give you a hint. It's on the slide.
It's going to shunt pyruvate into lactate.
A massive high anion gap metabolic acidosis, okay? Because it's in the name. You're literally introducing a strong acid into your bloodstream, all right? It'll shunt pyruvate into lactate, also compounding it, where you're also going to have a lactic acidosis on top of it. Very bad. Okay.
Disorders alone.
I'm sorry.
2 disorders. Remember? And
Yep.
That's how we get 2 disorders right there.
Yep. How it causes the visual disturbances. It will actually, the formic acid, it degrades the optic nerve itself, okay? That's why you're going to get these visual disturbances. That's why you're going to get eventually blindness, all right? Because if I'm shunting pyruvate into lactate, what is that pyruvate not turning into? How far did Dr. Tan go into the? Okay. So it does, instead of going into, because remember, pyruvate can turn into a number of things, right? 4 things specifically. Eventually ATP, yeah, but it'll go from pyruvate to the acetyl-CoA, and then the acetyl-CoA, we're going to go into the Krebs cycle, whatever. So if methanol will shunt pyruvate into lactate, not only do we have a lactic acidosis because of that, but we're not producing ATP the way we normally would, okay? Very, very bad. That will lead to cardiovascular compromise and a shock that is very, very difficult to treat, okay? Because it's not like your body's not lacking in beta stimulation or there's not like an increase in beta blockade or whatever. There's literally just not enough ATP for your heart to be able to do anything, okay? Very bad. That's what I'm saying. That's a number of things, like we've just discussed, 3 different things that can kill you with this substance. Okay, most lethal. Ethylene glycol, another very lethal alcohol. This was formerly found in antifreeze. All right, that's where people would encounter it most. You may still see a question either on the IBS-C test where you find somebody in their garage, they have altered mental status, and there is like neon green vomit near them, okay? What they're leading you towards is that this person, alcoholic, they were drinking antifreeze because it contains an alcohol, but it's a really lethal one. Drank the antifreeze, some of it threw up, but it didn't matter. It already caused our high anion gap metabolic acidosis. Luckily, it does not metabolize into formaldehyde and eventually formic acid, so we're not going to have like the same thing as our methanol. So the hallmark symptom here is renal failure, acute renal failure. So you're going to have lab tests that are consistent with renal failure, okay? Diethylene glycol, it's literally the same thing, only they doubled the amount of ethylene molecules. Very, very, these 2 are not quite as lethal, but like these 2 are also very lethal, okay?
If you add that renal failure, you're definitely going to die ethylene after all that.
Yep. And then the lesser lethal alcohols, we have isopropyl alcohol, ethanol, and propylene glycol. Propylene glycol is now what is in antifreeze. Like as far as an antifreeze product goes, it still does just fine. You know, like it works just as well as the ethylene glycol does. Only it's not nearly as lethal. Like it can still be very bad for you, but it's not, you know, too bad. Ethanol, oddly enough, so our alcohol, the alcohol that we drink, is one of the things that's used. I shouldn't say it's used. It's one of the things that can be very effective as an antidote to our toxic alcohol. Okay, the reason being is that, what was that enzyme again that I said that metabolizes their toxic alcohols? Alcohol dehydrogenase. Yep. Alcohol dehydrogenase, of all of the toxic alcohols, it has the highest affinity for ethanol. Okay, so if you the sort of classic presentation of this would be like the person that wants to kill themselves by imbibing a toxic alcohol, but they need a little liquid courage, and they don't realize that they're drinking the antidote. And they drink the antidote, then they drink what they think is the toxin, and nothing happens. Because none of your alcohol dehydrogenase cares about the methanol or the whatever. It's just, ooh, ethanol, I want some of that. Ethanol, yes. Okay. Let's skip over this for a second, because we'll just go to this we'll go to this first, and then because I'll hand you the other slides for this one. So what are you going to do? What are we going to do for preventing our patients from dying from toxic alcohol? Like I said, your focus is going to be first. What's the first thing that's not on this list that we're going to do if we can? It's the same thing with all of our toxins. Remove the offending agent if you can, right? And then our next focus is focus on preventing metabolism, okay? We're going to inhibit alcohol dehydrogenase if we can, or give it a substance that has a higher affinity. Brian already was goodly enough to add a star next to this one. You have to know what fomepizole is. Fomepizole is very important. It is a direct alcohol dehydrogenase inhibitor. You will not metabolize alcohol at all if you are administered fomepizole. You just won't do it, because all your alcohol dehydrogenase will be deactivated, and you will just simply pee the substance out before it can do anything to harm you. Okay? And then, like we discussed before, ethanol has a higher affinity for alcohol dehydrogenase. And believe it or not, this dose is actually the medicinal dose of booze. You're going to do 4 milliliters per kilogram of 40 proof, or 2 milliliters per kilogram of 80 to 100 proof booze. A lot of booze. It is a lot of booze.
Can you mix it with something?
Let's see how much mine does.
Yep. A lot of booze.
200 milliliters? That's nothing.
Okay, hey Nate, I'm sorry. Can you explain again how the fomepizole works?
Fomepizole? Fomepizole, so alcohol dehydrogenase is the enzyme in your body that metabolizes alcohol. Fomepizole deactivates that. It renders it inert, like to where like that enzyme that is responsible for taking that methanol and turning it into the formaldehyde and the formic acid and altering your serum odds and giving you that high anion metabolic acidosis. If this is not present, none of that can happen. Okay?
So if you have ethanol toxicity, you can't use ethanol, obviously. It's just for the first two, the methanol.
Right, because ethanol. So if you're suggesting like, what do you do if somebody who's like intoxicated on ethanol to the point where they're like completely stuporous, GCS of 3, you're getting nothing out of them whatsoever. What we're going to do with those people is protect their airway. Is they bought themselves a tube. They're going to get intubated. Probably have an OG tube put in, and then if it's depending on what their kidney function is, they might dialysize them, or to get some of that, or they'll just allow it to sort of run its course naturally. So, yeah, because like the amount of ethanol that it would take to like kill you acutely, like a third party would have to be involved. Like you would pass out and not be able to, like physically not be able to pick up another drink, like before it gets anywhere near killing you. Like somebody would have, like literally, like somebody would have to put like a feeding tube in and just like continually infuse you with booze to the point where it would kill you. That's next. Okay. Okay, so we're going to talk about how we figure out, if we have no evidence whatsoever, how do we figure out if we have a toxic alcohol ingestion, okay? The osmolar gap. Is anyone familiar with the osmolar gap? Okay, so we know that you can get your serum osmolality, right? That's actually a calculated value, okay? So like you will draw the blood and you will have it analyzed, and the computer will or the lab technician will use the equipment and say, okay, this is what your serum os should be, okay? And then what you're going to do to calculate the osmolar gap is you're going to take, and the order of operations applies, okay, so hopefully everyone remembers that. You're going to take whatever your sodium is, times 2, glucose divided by 18, BUN divided by 2.8, and then you're going to add all of those values together. Normal, quote unquote, should be about 290, all right? Very, very straightforward. The machine is giving us the exact value of what it's supposed to be, and we're doing a calculation to make sure there aren't any hidden substances. Any substances that, because the way that your body, or sorry, that the machine does it, is it looks at the things that it measures. It doesn't measure alcohol, okay? It doesn't measure that. So it looks at the things that it does measure, it punches those numbers into an equation, and it's like, this is what your serum odds should be. And then what we're going to do is we're going to say, okay, we're going to calculate to see if the machine is right. This number should be plus or minus 10 of what the machine is giving us. All right, so an example. If my sodium is 135, my glucose is 100, my BUN is 18, what would my calculated serum odds be? A sodium of 135, glucose of 100, a BUN of 18. And plug it into this equation and tell me what that number would be. What would my calculated serum odds be? BUN is 18. Mm-hmm. And it might help your math. It's totally okay if instead of 2.8 you put 3. That's totally fine too. If you don't want to end up with a number with a repeating decimal point, 2.8 can be 3. Okay? That's totally fine. Glucose is 100, sodium is 135, BUN is 18. So, Jen, what you're having trouble with is this is supposed to be a division sign, okay? So, whatever your glucose is divided by 18, whatever your BUN is divided by 2.8, okay? And follow your order of operations. You know, your please excuse my dear Aunt Sally.
281.9.
Yep, 282. 281, 282, very good. So that's what you calculated. And if the machine spits out at you and says, you said, okay, it's supposed to be 281. 281's, you know, like fine, totally normal. But then the machine spits it out at you and says, it's 270. You know, or like it's a different, it's a number that's 10 off, right? That's your osmolar gap, okay? So if the machine tells me the serum odds is 310, I have a big osmolar gap of 29. Okay, I got a big problem. Big problem. All right, I should not have that as osmolar gap. Something is affecting my serum odds in a very, very dangerous way. Okay? The list of things that can cause an osmolar gap is very small. It's literally these 8 substances. That's it. These are the only things that can cause an osmolar gap. Nothing else will produce that. Okay? 3 of them have a high anion gap. Sorry, 3 of these will also cause a high anion gap metabolic acidosis. So if you have an unknown toxic ingestion, I have a high osmolar gap and a high anion gap metabolic acidosis. Congratulations, you just diagnosed your patient with toxic alcohol ingestion. It's that simple. Okay? It is similar. It is a sugar alcohol. Yeah, it's a sweetener, artificial sweetener. Okay? So it's very, very simple. If you have a stuporous patient, you don't know why, you know, like they're deteriorating. We pull some labs and we see they have a high anion gap metabolic acidosis. I have a high suspicion that it was an ingested substance of some sort. And then I calculate my osmolar gap. My osmolar gap is also high. Cool. Give me some alcohol dehydrogenase, or give me some fomepizole, and let's put this baby to bed. Okay? Easy peasy. So here's the other 2 slides. Actually, if you want to take one and pass it. So we're going to revisit something about ethanol. Okay? So I've kind of talked about, sort of glossed over a few like drugs of abuse and kind of what their withdrawal symptoms look like. And it's not that those are unimportant to know, but with ethanol, with understanding what you are looking at in terms of withdrawal is actually very important because ethanol withdrawal, unlike a lot of other drugs of abuse, this can kill you, okay? So acute alcohol intoxication, we know we have slurred speech, ataxia, emotional lability. If anybody was wondering, lability is the opposite of stability. So if it's, they're emotionally stable, or emotional stability, would be something that, a non-intoxicated person, emotional lability, which is why, your drunk friend may go from hugging you and telling you that they love you and you're the best person they've ever met. Did you have 2 over there, Tyler?
Yeah, I have 2. There was 4.
Was there?
Right now, there's just 1.
So, and disinhibition, okay? So something happens when you take alcohol, and we already discussed that it directly stimulates GABA receptors, right? And we already know, I've already asked you a bunch of times, that GABA is your body's primary inhibitory neurotransmitter. Do you guys remember glutamate? Like when we're talking about ketamine, right? What is glutamate? Glutamate is your body's primary excitatory neurotransmitter, okay? When you ingest alcohol, not only does alcohol stimulate GABA receptors, it also decreases glutamate levels. It doesn't have any effect on a glutamate receptor. However, it will directly decrease glutamate levels in your body, all right? Chronic alcoholics, what will happen to them is because they are in a chronic state of constantly having alcohol in their body, their glutamate receptors will undergo a process called upregulation, okay? Meaning they become way more sensitive, all right? So it takes far fewer or far less of that substance, glutamate, to get the desired result, okay? So what will happen is your glutamate receptors upregulate, they will become much more sensitive. Your GABA receptors, on the other hand, will downregulate, becoming much less sensitive. Okay, that's what's happening to you when you quote unquote build up your alcohol tolerance, is your GABA receptors are actually becoming less sensitive. That's what you're doing, okay? This is an important thing to understand when we talk about alcohol withdrawal, okay? So alcohol withdrawal, it's classified in 4 stages. They do overlap, okay? The first stage of alcohol withdrawal is 0 to 36 hours, and it's exactly how it's there. The GI upset, upset stomach, mild tremors, not full on, like tonic-clonic movement, but just, like if you've ever seen an alcoholic that hasn't had a drink in a while, they just get that shaky hand. That's what we're talking about, okay? Agitation, insomnia. Remember, these people, they had those glutamate receptors downregulated, so they're much, much, much more sensitive. And now that they don't have a substance in their body that is actively eliminating glutamate, now they're insomniacs, okay? Because there's not too much. There's actually probably a normal level of glutamate in their body. However, those glutamate receptors are supercharged, okay? So that's where the insomnia comes from, okay? The second stage, the 12 to 48 hours, is what we call alcoholic hallucinosis, is what this is called. This is supposed to be alcoholic. Sorry, I wrote the slide this morning, hence the extra pages. Alcoholic hallucinosis, okay? Alcoholic hallucinosis is the patients will be experiencing hallucinations The difference is, or the thing that's unique about this is that their orientation is intact. Okay, they will be able to tell you who they are, where they are, what's going on, and they will be aware that they're having visual hallucinations. Okay, alcoholic hallucinosis. Okay, stage 3, 6 to 48 hours, we have withdrawal seizures. Okay, they will actually have like full-on seizures, right? Again, if we think about what's happening here, their bodies are now super sensitive to glutamate, and they're very blunted to GABA, so we're going to have seizures, withdrawal seizures. Again, typically between 6 and 48 hours, okay? And then we get to the delirium tremens. If you guys have ever heard of delirium tremens, that's when we get to the 48 hours plus. Okay, when we get beyond that 48 hours, this is a profound alcoholic. They drink, 15 beers a day, and they haven't had one for 48 hours. They are now going to be in DTs, okay? The difference between alcoholic hallucinosis and delirium tremens is now our orientation is no longer intact. They are suffering from hallucinations, but now they have no idea who they are, where they are, what's going on. They're very dangerous if they are in delirium tremens, okay? Because they have no idea what's happening, all right? We also have cardiovascular compromise here because of that sympathetic overdrive, okay? That sympathetic overdrive being secondary, again, to their body's primary inhibitory neurotransmitter. Those receptors are burnt out, they're blunted, they've just been beaten up so bad that they don't really work very well, and those glutamate receptors are really, really sensitive. And that's where we're going to get cardiovascular compromise secondary to what we call sympathetic overdrive, okay? So this is where they're going to have their blood pressures are going to spike, their heart rates are going to spike, right? And they're going to require like some pretty intensive intervention at that point. Beta blockers are okay to use for rate control. Things like labetalol are okay to use for things like blood pressure control. But yeah, like you're going to most likely need to intubate these people, but you're going to have a hell of a time getting them properly sedated and pain controlled for it. Ketamine would be a good drug of choice here, because remember what ketamine does is it blocks glutamate, right? And these patients, they have the supercharged glutamate receptors, so something like ketamine would actually probably be better for them, right? And it also doesn't use that receptor, doesn't use that GABA receptor. So like it's that receptor that already isn't working very well, you're not using it, if you're going to use it. So just wanted to give you guys because again, it's not a toxicological problem in the sense that we're going to give a reversal agent for it, but absolutely this is a toxicological emergency, and it's important to.
Do we need to memorize the time frames, or just the fact that these are the things that can happen to someone in also?
If I were to say for you to like memorize the things that come from this slide, it would be the difference between stage 1 tremors and stage 3 seizures, and the difference between hallucinations with orientation intact and hallucinations with no intact orientation. Okay? That's what I would say, like, if you're only going to remember like one thing from this, is like those would be your takeaways. Okay? And sorry, that's kind of also in reference to your question, Donnie, where it's like acute ethanol intoxication is very rarely going to kill you, like in and of itself. Whereas, I said without intervention, right? Whereas like this, like alcohol withdrawal, and 48 hours is not a very long amount of time, like absolutely can kill you, for sure. So. Cyanide poisoning. This would be resulting in a histotoxic hypoxia, okay? It directly interrupts the electron transport chain, right? So after we've put our pyruvate's been turned into the acetyl-CoA and it's been run, through the Krebs cycle, and then goes to the electron transport chain to make some ATP. Cyanide directly interrupts that process. Okay, so you're going to get, like the slide says, oxygen gets there, because it's oxalative phosphorylation, but oxygen gets there to contribute. It's part of the process, but nothing happens. Okay? Like it says on here, this is most encountered in fires. Typically, carpet burning is what is going to release cyanide. Okay? I don't know if they still say that, like, is it the bitter almond smell? I don't know if that's still a thing or not. Signs and symptoms, so this is the dizziness and giddiness specifically. So this is the fireman that you've pulled out of the fire, and you're trying to talk to him, and he just can't stop giggling, like, regardless of, like, hey man, 4 kids just died in that fire, and he's like laughing at you. Like, that person is not a psychopath. It's very likely that he has cyanide poisoning. Okay? Chest pain and tightness, confusion, altered mental status, difficulty breathing, nausea, headache. So a lot of things that are not necessarily super specific, but the dizziness and the giddiness is. So that's like what would be considered your quote-unquote hallmark symptom, right? The cherry red skin that you'll hear people refer to is an extremely late sign, like not something that you're likely to see in the acute phase whatsoever. And like I said previously, the bitter almond quote-unquote smell is unreliable at best. It's not terribly, it's not impossible that you'll see these two mentioned on a test, like cherry red skin or bitter almond smell. But again, cherry red very, very late, and like the slide says, mostly happening when they're after they're already dead. These are the people we're going to do the hydroxycobalamin, the vitamin B12. Okay. It contains cobalt compounds that can bind to and detoxify cyanide. Okay. Before it inhibits the cellular respiration. Okay. And it turns into something called cyanocobalamin, which is then excreted through your urine. So that's the mechanism how that happens, is you have the cobalt compounds, it binds directly to the cyanide and turns it into something else that is inert, and you pee it out. Okay? The cyanokit, the amyl nitrate and sodium nitrate, it oxidizes your hemoglobin into methemoglobin, which scavenges cyanide and removes it from the body. Sodium thiosulfate also bonds to cyanide to create thiocyanide. Thiocyanide is 100 times less toxic than cyanide, and it's easily secreted in your urine. Okay? So that's how they work, but the takeaway here is, like, those are your treatments of choice once you've identified cyanide poisoning. The BCs carry the cyanokits, right? So, yeah, so this is something that can and should be deployed pre-hospital as a first-line treatment when we've identified, we check all the boxes here for cyanide poisoning.
Kind of off topic with that. Can that be used for CO poisoning? They've seen like some things say that it can, and then some that are like kind of mixed on it.
The cyanokit or the hydroxycobalamin? The hydroxy, the B12 can, for sure. I don't know about the other things in the cyanokit though. Yeah, but yeah, B12 for sure.
So the short answer is no.
No.
So is drinking 5 hour energy? It's like 28,000% of your daily value of B12.
Oh yeah, there you go. Yeah. Carbon monoxide, colorless, odorless gas. Unfortunately, the symptoms of carbon monoxide poisoning are vague and pretty nonspecific. In the acute phase, you can see headaches, dizziness, nausea, vomiting, altered mental status, tachycardia, hypotension, dysrhythmia. Sounds like a whole bunch of things that we've discussed today. It's not super specific. It has a 200 times more affinity for hemoglobin than oxygen. Okay, and it causes a leftward shift on the oxyhemoglobin dissociation curve. I know that our pulse oxes are supposed to be able to pick this up. I just don't know how reliable they are.
You have to cover them up, make them dark in the room.
Yep. So yeah, but I mean, even with that, I don't know how reliable that is, to be completely honest with you. Okay. What we're going to do is the hyperbaric chamber. It's like, so we're going to start them out with like just as much high flow O2 as we can possibly muster. You know, like this would be a great thing to deploy, like if we ever unlock the high flow nasal cannula on our Hamiltons, this would be a wonderful application for that. Okay, we're not going to talk about that. I don't think you need to know that. Caustic injection. This is going to be the last few things that we talk about, last couple things to talk about. This could be either acids or alkalines. Okay, this is the drinking Drano. Not really sure why you would want to do that, but so like I said, it causes tissue injury, altering the state of molecules, covalent bonds. A pH greater than 11.5 is typically the point at which a strong alkali will cause injury through something called liquefaction necrosis. That's an important term that you guys should write down, that strong alkali injury causes liquefaction necrosis. I believe Brian already talked about this in the burn lecture. This is just specific to if it's ingested, so like what it's going to do to your mucous membranes, right? A pH of less than 2 is typically the point at which an injury is caused by coagulation necrosis, which is what what acid is doing to you is coagulation necrosis. So yeah, if it's above 11.5, that's going to cause liquefaction necrosis. pH of less than 2 is coagulation necrosis. Alkalis are considered worse, mostly because acids will typically interact with whatever mucous membrane they first come in contact with. They will cause their coagulation necrosis, and that's kind of it. They'll sort of stop going. Whereas with an alkaline, the liquefaction necrosis will continue to go deeper and deeper, like into the tissues. So it'll cause damage to other structures, like outside of the esophagus. Like a strong acid will, again, coagulation necrosis. It'll cause a great deal of harm to your esophagus, where a strong alkali will just keep going and until the substance is used up, for lack of a better term, it'll just keep going. Okay. So when you're assessing your patients, you want to consider the 5 W's. Who, meaning more specifically your patient demographics, age and weight, if there's any witnesses that saw anything happening, what the characteristics of the poisons. If you can find the offending agent, bring it with you, or take a picture of it or something. Give the hospital some indication as to what it is that they're dealing with, so that they can figure out how best to counteract what's happening. When, obviously the time and date. Where, the route, was it swallowed? Did they accidentally inhale it? In some sort of mist form, something like that. And where, the why. Was this intentional? Did they try to kill themselves by doing this? So here's a more detailed description of what I just discussed. On the caustic adjusting things like battery acid, you're going to protect the airway. There is some limited benefit to diluting an acid with water. It's limited, but there is some benefit. Same thing with an alkali. You can try it. That's just something like lye. And for sure, these patients are going to require surgery. A lot of damage has been done, and they're going to require surgical intervention. Okay, so questions that you might see on a the IBS-C test. Again, you want to know the difference between coagulation necrosis, liquefaction necrosis. The IBS-C loves knowing which one of these two things is worse. So just know that lye is considered the worst, alkali is considered the worst of the two. So.
You have the acidotic patient just swallow some calcium chloride.
Yeah. Yeah.
See if that helps.
Yeah, see if it works. Yeah, whatever. All right, do we have any questions on toxicology? Was there anything that I didn't cover too quickly, or that you got a question about?
A lot there, a lot of words there.
A lot of words there, a lot of words. And like I said, the IBSC loves to test you on reversal agents. Loves it. They want to know if you know how to identify a toxidrome and what to do about it.